the 21st South Asian Health Foundation Global Virtual Conference, and we're going to move back to our first talk today, this afternoon, is the symposium sponsored by Novo Nordisk, and today I've got the pleasure of chairing a friend, but also colleague, Dr. Abtarani, who is, if you don't know him, you will certainly not forget him after this. He's a fabulous speaker, and he's going to be talking about GLP-1 receptor agonist as the second-line drug of choice for South Asians. And just to give you a bit of background about him, he's both a senior lecturer and an honorary consultant in endocrinology, diabetes and weight management at the University Hospitals Birmingham NHS Foundation Trust. He is also an expert advisor to NICE, as well as a member of the Strategic Council of the Obesity All-Party Parliamentary Committee in the UK. He's renowned internationally for his research and presents in the fields of diabetes-related neuropathy, sleep and obesity. And he was an absolute fantastic speaker, so I'm going to hand over to Abtarani now.
Thank you very much, Sarah, for the very nice introduction. Hello, everyone, and I thank SAHF for the very kind invite. It's a great pleasure to give this talk with you here today. I was asked to answer the question, are GLP-1 receptor agonists the second-line drug of choice for South Asians? I will start with my disclosures. So in order to answer this question, I thought I would firstly provide an overview of GLP-1 receptor agonists and their treatment and their place in the treatment paradigm of people with type 2 diabetes and how their efficacy, whether on glucose or weight or cardiovascular outcomes, compare to other glucose-lowering agents. Then I will focus on comparing Asians versus non-Asians in terms of the pharmacodynamics of GLP-1 receptor agonists, as well as cardiovascular outcomes. I will also set the case why South Asians need specific data regarding the glucose-lowering agent's efficacy and cardiovascular outcome and safety in this population. And then I will discuss the place of GLP-1 receptor agonists in the treatment paradigm of type 2 diabetes in South Asians. And after that, I will summarize and I will discuss future research. So let's start with an overview of GLP-1 receptor agonists. As you know, GLP-1 has multiple functions. In the pancreas, it increases insulin secretion and inhibits glucagon secretion, both in a glucose-dependent manner. In the liver, it reduces hepatic glucose output. On the cardiovascular system, it reduces systolic blood pressure, increases the heart rate, but we know that from cardiovascular outcome trials that some agents or some drugs in this class had cardiovascular benefits. And in the hypothalamus and the brain, it increases satiety, reduces energy intake, and as a result of that, it achieves weight loss. And we know that these effects of GLP-1 are dependent on the levels. So with DPP-4 inhibitors, where we get slight increases in active GLP-1 levels, we mainly start getting the glucose-dependent increases in insulin secretion and the glucose-dependent inhibitions in glucagon secretions. However, with the greater levels that you get with GLP-1 receptor agonist, you get more of the insulin secretion and glucagon inhibition effects, but you also start getting the weight loss effect and the increased satiety and the reduction in gastric emptying. And we now even know that with even higher dosages, you get greater weight loss effects, as is shown with semaglutide, liraglutide, and as well as dulaglutide. However, when we talk about GLP-1 receptor agonists, although they are one class, there is a lot of heterogeneity in this class, and they are not really one product. So some of the products are oral, such as oral semaglutide. Some of them are injectable, and these are obviously the majority in the class. The injectable, some of them are short-acting, where they get injected more than once daily, and some of them are longer acting, injected daily, such as liraglutide, or weekly, such as exenatide weekly, dulaglutide, and semaglutide. Also, there are differences in the pharmacodynamics, not only in the pharmacokinetics. So we know that the shorter acting GLP-1 receptor agonists have greater effects on postprandial glucose compared to the weekly. However, the weekly GLP and the longer acting GLP-1 receptor agonists have greater effects on fasting plasma glucose and greater effects on HbA1c reduction compared to the short acting GLP-1 receptor agonist. Similarly, the impact on major adverse cardiovascular events seems to be greater with the longer acting GLP-1 receptor agonist compared to the shorter acting. So these drugs in the class are not exactly the same, and we need to keep that in mind when we are thinking what will be the best add-on agent to metformin. So let's look at what happens when drugs, glucose-lowering agents, are added to metformin. If we focus on the figure on your right-hand side, where the arrow is. Now, this is from a network meta-analysis, which was published in August 2020. The next few slides will be from this network meta-analysis, and I would recommend you read this meta-analysis for more information. But if you look at HbA1c reduction when glucose-lowering agents were added to metformin background therapy, we will see that the greater reductions in HbA1c was achieved mainly by GLP-1 receptor agonists and insulin treatment, with the greatest reduction was achieved by subcutaneous semaglutide. And when we compare GLP-1 receptor agonists to other glucose-lowering agents, we can see that GLP-1 receptor agonists, when added to metformin, achieved greater HbA1c reductions when compared to SGLT2 inhibitors, sulfonylureas, and pioglitazones, also DP4 inhibitors and alpha-glucosidase inhibitors, and they had similar reductions in HbA1c when compared to insulin treatment. And if we look at individual drugs within the class, and this obviously slide is busy because there's lots of agents on it, but if you look at semaglutide, you will see that semaglutide achieved greater reductions in HbA1c when added to metformin compared to all other glucose-lowering agents, including insulin treatment. When it comes to weight loss, the data is less clear, but there is some data. So in the top figure, we will see a comparison between semaglutide once weekly with empagliflozin in orange, semaglutide in blue, and on the y-axis you see the changes in weight. This data was obtained from indirect comparison. The empagliflozin data was from the Pioneer study, and the semaglutide data was from the SUSTAIN study. And what you can see that semaglutide produced greater weight loss compared to empagliflozin, and that weight loss was by about 1.5 milligrams. Semaglutide subcutaneously once weekly was also compared to canagliflozin in the SUSTAIN 8 study, and what you see here is greater reductions in weight with semaglutide compared to empagliflozin in red, semaglutide in blue, and these differences were about 2 kilograms roughly in weight. What about mortality and cardiovascular outcomes? So on the left-hand figure, we see the all-cause mortality in patients who are at increased cardiovascular risk receiving metformin-based background therapy. And you can see that oral semaglutide and empagliflozin had the greater reduction in all-cause mortality, slightly greater with oral semaglutide compared to EMPA. When we look at those with low cardiovascular risk, you can see that most of the agents at the top, which produce the greater reduction in all-cause mortality when added to metformin, are actually GLP-1 receptor agonists, but these were not statistically significant as the figure shows. When we compare the classes together, GLP-1 receptor agonists produced trends towards lower all-cause mortality compared to all other agents, except SGLT2 inhibitors. There were neutral effects compared to SGLT2 inhibitors. And similar picture was regarding cardiovascular mortality. When we looked at myocardial infarctions, GLP-1 receptor agonist seems to have similar reductions in terms of GLP-1 receptor agonist, in terms of myocardial infarction compared to other agents. However, when it comes to stroke, GLP-1 receptor agonist seems to lower the risk of stroke compared to SGLT2 inhibitors and sulfonylureas, and similar effects compared to DPP4 inhibitors and pioglitazone. And this reduction in in stroke incident was mainly driven by data from semaglutide and dulaglutide. What about those in low cardiovascular disease risk? There is nothing really significant. The results are largely similar to the slides I've just shown you, which included people with high cardiovascular risk, but there were trends in terms of all and cardiovascular mortality. No drug class was superior over the other, but the trends were in favor of GLP-1 receptor agonists versus all other agents, and for SGLT2 inhibitors versus all other agents except GLP-1s. For myocardial infarction, both GLP-1 receptor agonists and SGLT2s were superior to SUs, and there were trends favoring GLP-1 receptor agonist versus all other agents, except when compared to SGLT2 inhibitors. And with stroke, there were trends favoring GLP-1 receptor agonist versus all agents. We also know that the risk with GLP-1 receptor agonist as well as SGLT2 inhibitors, the risk of hypoglycemia is low compared to sulfonylurea, glanides, or insulin treatment. And as a result, when it came to the joint ADA-ESD recommendations, they placed a lot of prominence, they've put a lot of prominence to assigning the second-line treatment based on the presence of cardiovascular disease, heart failure, CKD, and the impact of weight. So in these guidelines, as you know, in those who are established atherosclerotic cardiovascular disease or CKD, the recommendation was to add GLP-1 receptor agonist or SGLT2 inhibitor to metformin background. And from the data I've shown you, that in the impact of GLP-1 receptor agonist seems to be greater compared to SGLT2 inhibitor when it comes to glucose lowering effects and some cardiovascular effects, particularly stroke. However, in those who have heart failure or CKD, SGLT2 inhibitors are clearly superior to GLP-1 receptor agonist when added to metformin. When the aim of the treatment is to bring the HbA1c down in those who do not have established cardiovascular disease, then the guidelines recommend any agent can be added. However, as I've shown you, that the greater reductions in HbA1c was achieved by GLP-1 receptor agonist, especially semaglutide weekly. And when weight is the focus, then you can use either GLP-1 receptor agonist or SGLT2 inhibitors. But again, from the data that I've just shown you, GLP-1 receptor agonists have a better edge in terms of weight loss compared to SGLT2 inhibitors, especially with semaglutide. And when price is the concern, then both GLP-1 receptor agonists and SGLT2 inhibitors are expensive, and the treatment will become mainly based on SUs and TZDs. So up till now, I've shown you that as an add-on to metformin, GLP-1 receptor agonists do very well and seems to be more efficacious than other glucose-lowering agents in terms of its glucose-lowering effects, weight loss effects, as well as cardiovascular outcomes. Why do we need to give a specific consideration to South Asians, though? Isn't that data enough to say, well, GLP-1 receptor agonist and SGLT2 inhibitor seems to do well as second-line agents added to metformin? Maybe GLP-1 receptor agonists have slight edge in certain populations. Why do we need data in South Asians? Well, South Asians are actually a specific group, and they are different from white Europeans when it comes to type 2 diabetes. So this is data from the UK Asian Diabetes Study, and this is data from Dr. Bellari. And as you can see, that patients who are South Asians compared to white Caucasians with type 2 diabetes, the South Asians were younger, they had lower body mass index, they had higher HbA1c, despite using more insulin treatment. So the South Asians with type 2 diabetes seems to have more severe disease at a younger age and lower BMI. In addition, in this population-based study, which was performed by Dr. Ms. Mulhem, who is a PhD student working with Dr. Niranthara Kumar, Professor Hanif, and myself at the University of Birmingham, and we compared the South Asians to white European. There was about 100 South Asian in this study, and 100,000 South Asians in this study, and 200,000 white Europeans. You can see that the South Asians had increased risk of diabetes, hypertension, ischemic heart disease, and heart failure compared to white Europeans. They had lower risk of atrial fibrillation and mortality. And whether you looked in Indians, Pakistanis, or Bangladeshi, you can see similar trends. And whether you look in those with diabetes and without diabetes, you also find similar trends. So South Asians have increased risk of cardiovascular disease and type 2 diabetes compared to white European. And when they have type 2 diabetes, they have more severe disease at younger age. And hence, it's important to understand the underlying mechanisms and what's the important, which treatment is best for South Asian people with type 2 diabetes. And in order to understand the mechanisms, there is very nice reviews, which I have referenced in this slide. Naveed Sattar have very nicely summarized some of those mechanisms, with South Asians having lower ability to store subcutaneous fat, resulting in increased visceral fat deposition, and the lower muscle mass. All of that drives the increased insulin resistance. And with a lower beta cell capacity, then they are more likely to develop type 2 diabetes. Add to that the higher inflammation that is observed in South Asians compared to white Europeans, the lower levels of adiponectin, and the more adverse lipid profile. All of that results in increased risk of cardiovascular disease that we see in South Asians compared to white Europeans. So it is very important that we ascertain what is the best treatment option in people of South Asian origin with type 2 diabetes, not only just from glycemic control point of view, but also from cardiovascular outcome point of view. So let's look at the evidence. What evidence do we have for the best second-line glucose-lowering agent in South Asians with type 2 diabetes? Is GLP-1 receptor agonist really the best option, as the title or the question in the title slide was given to me? So first of all, we need to understand that the data about South Asians in particular are very limited. So that's one of the major deficiencies in this area of research. There's some evidence about Asian populations, but Asian populations are heterogeneous. They are not exactly South Asians. There are other Asians as well, such as Chinese and Japanese. But I will try to highlight data specific to South Asians when it does exist, but this is very little in the literature. So in this study, in this meta-analysis, which tried to compare the impact of GLP-1 receptor agonist on glycemic measures, they divided the study, the RCTs, into those who are Asian dominant, that means more than 50% of the participants were Asians, versus non-Asian dominant studies. And when I say here Asians, I don't mean South Asians. I mean Asians in the wider sense, rather than just specifically South Asians. And what you can see here is that when it comes to HbA1c reductions, obviously GLP-1 receptor agonists work well in both Asian dominant studies and non-Asian dominant studies, but there was a greater reduction in HbA1c observed in those Asian dominant studies compared to the non-Asian dominant studies. Similar trends were observed in fasting plasma glucose, and there were trends in terms of achieving a target HbA1c below 7% or 6.5% in favor of the Asian dominant studies compared to the non-Asian dominant studies. In other words, those studies that included more than half the participants as Asians, GLP-1 receptor agonist seems to produce greater glucose or glycemic effects. And in this study that looked at the effects of GLP-1 receptor agonists in Asians in relation to having normal or high BMI, and in this study they used the ethnic specific BMI's cutoffs in order to define what normal and what high BMI, you can see that GLP-1 receptor agonists work in both people who have normal BMI or overweight and high BMI, and a BMI consistent with obesity. the effect seems to be greater in those with normal BMI, but there's still quite a big effect in those who have overweight and obesity, and that's in regards to a variety of glycemic measures, whether it is HbA1c or fasting plasma glucose, or 2-hour postprandial glucose, or achieving HbA1c targets of 7% or 6.5%. So they do work regardless of the weight, although they work even greater in those of normal weight. Again, in this study, we're trying to show the impact of GLP-1 receptor agonists on HbA1c and weight based on ethnicity. This is a pooled analysis from the SUSTAIN program, and they compared the effects on HbA1c and weight in Caucasians, Asians, and Black people with type 2 diabetes, and achieving an HbA1c target below 7% or below 6.5% was similar across all ethnic groups. If anything, GLP-1 semaglutide seems to do slightly better job in Asians compared to other ethnicities. And when it comes to the absolute reductions in HbA1c, you can see that semaglutide resulted in a greater reduction in HbA1c in Asians compared to other ethnicities. The dark blue here, which I'm highlighting, is the 1 milligram dose, while the light blue is the 0.5 milligram dose. When it comes to weight, we find slightly similar patterns in that achieving a weight loss target of 5% or 10% seems to be similar in Asians compared to all other ethnicities with semaglutide. But when it comes to the absolute number in terms of weight loss, it seems that semaglutide results in less weight loss in terms of kilograms compared in Asians compared to other ethnicities. But as I said, achieving 5 and 10% weight loss target seems to be similar in Asians compared to other ethnicities with semaglutide. However, what about other agents? What about DPP-4 inhibitors? So in this meta-analysis in which they defined Asian dominant studies as those who have 70% Asian population, you can see that DPP-4 inhibitors did work in both Asians and Caucasians, but there was no difference between the two groups, i.e. the efficacy was similar in terms of HbA1c reductions in Asians and non-Asians. While with SGLT2 inhibitors, the results were similar to GLP-1 agonist in that SGLT2 inhibitor seems to produce greater reductions in HbA1c compared to white studies. SGLT2 inhibitors produced greater reductions in HbA1c compared to in Asian studies compared to white non-Asian dominant studies. However, when we specifically look at comparing the Asian studies with non-Asian studies, again in this analysis, they use the 70% participants to define what Asian dominant studies and what is non-Asian dominant studies. When we compare SGLT2 inhibitor when added to metformin, we can see that there is really no difference in terms of HbA1c reductions when SGLT2 inhibitor added to metformin in Asian dominant in Asian patients versus non-Asian patients. The impact on fasting plasma glucose was similar, and the impact on weight was largely also similar, although there was a slight trend for greater weight losses in non-Asian population, but it is not really clinically meaningful. Since then, there has been several consensus statements and expert opinions showing that SGLT2 inhibitors, when added to metformin in Asian populations, work in a similar way or a similar efficacy compared to non-Asian population. So what I've shown you up till now is that it seems that when added to metformin, GLP-1 receptor agonists have even greater efficacy in Asian dominant studies compared to non-Asian dominant studies, while other glucose-lowering agents seem to have similar efficacy, except that SGLT2 inhibitors also produced greater reductions in HbA1c in Asian dominant studies, but not when added to metformin. So take that into account that also I have shown you in the previous slides that a GLP-1 receptor agonist resulted in greater reductions in HbA1c and weight compared to other agents glucose-lowering agents, if they work even better in South Asians, in Asians, then that will suggest that probably they are really the drug of choice in this population. But the situation is not exactly as clear-cut as I will show a bit later. However, that's glycemic effects and weight. What about cardiovascular outcome studies and cardiovascular benefits in terms of Asians versus whites? So in this analysis, where they looked at the once-weekly GLP-1 receptor agonist, exenatide and semaglutide, as well as the daily liraglutide, they've done a post-hoc analysis, and what they concluded is that long-acting GLP-1 receptor agonists reduce the risk of major adverse cardiovascular events and cardiovascular deaths in high-risk patients with type 2 diabetes, which we already know, of course. But in this study, they found that this effect particularly was evident in the Asian population. And in this extensive data analysis from Singh et al., in which they even chased data which was not published, and they looked at the cardiovascular outcome studies, they found that GLP-1 receptor agonists, and they looked at Asian patients in the cardiovascular outcome studies, they found that GLP-1 receptor agonists reduced the 3-point or the 4-point major adverse cardiovascular events in Asian patients who were included in these studies, while there wasn't really much effect in terms of SGLT2 inhibitors in Asian patients. But obviously this is a post-hoc subgroup analysis, and hence these studies were not designed to examine the impact of ethnicity. However, this analysis suggests that when it comes to cardiovascular benefits, GLP-1 receptor agonist seems to be better than SGLT2 inhibitors in terms of reducing major adverse cardiovascular events from the cardiovascular outcome trial. Again, from the CVD REAL studies, which looked at renal outcome, this is 50% reduction in creatinine or end-stage renal disease. This is end-stage renal disease. You can see, for example, in Japan, here and here, that there are benefits in terms of SGLT2 inhibitors on cardiovascular outcomes in real-world data. So, to summarize so far, compared to other oral glucose-lowering agents, GLP-1 receptor agonist seems to result in greater HbA1c reductions. When added to metformin, semaglutide resulted in greater HbA1c reductions compared to other glucose-lowering agents. In high cardiovascular risk patients receiving metformin, GLP-1 receptor agonists and SGLT2 inhibitors have greater reductions in mortality, and GLP-1 receptor agonists reduce the risk of stroke greater than other agents. However, the GLP-1 receptor agonists have heterogeneous clinical efficacy, and some of the data is agent-specific and not class-specific. In Asians, and that's not supposed to be South Asian, so apologies for the typo here. In Asians, GLP-1 receptor agonist seems to be more effective in Asian patients compared to non-Asian patients. SGLT2 inhibitors and DPP4 inhibitors are similarly effective in terms of glycemic control and weight loss effects in Asians and non-Asians when added to metformin. In cardiovascular outcome trials, only GLP-1 receptor agonists were associated with cardiovascular benefits in Asian patients, not SGLT2 inhibitors. However, as I said, SGLT2 inhibitors showed benefit from real-world data. So in order to answer the questions, are GLP-1 receptor agonists the second-line drug of choice for South Asians? The data about South Asians is very limited, it's really mainly from Asians. So the answer is yes, probably, but not definitely. Why probably? Because there's greater glycemic and at least comparable weight loss effects compared to non-Asians with GLP-1 receptor agonists, while other agents have similar efficacy to non-Asians. While other agents have similar efficacy to non-Asians, i.e. GLP-1 receptor agonist seems to work better in Asians, while other agents or other drugs seems to work as good in Asians as non-Asians. So this suggests that GLP-1 receptor agonists are probably the strongest in class in Asians. And it is the only class based on that analysis to show that cardiovascular benefits from cardiovascular outcome trials. However, it's not definitely, because a lot of this is subgroup and post-hoc analysis, which violates randomization. Asians is not a homogeneous group and is not specific to South Asians. Studies in Asians are mostly based on aggregate data rather than individual patients, i.e. studies with predominant Asian populations rather than individual patient data. And we know from the CVD reel that SGLT2 inhibitors work in some Asian countries as well. And the differences observed between GLP-1 receptor agonists and SGLT2 inhibitors in Asian population are relatively small. So there is a question whether they are clinically meaningful or not, and that will depend on which outcome measure and which population we are examining and which agent as well. So we really need more research data to answer the question that was posed to me at the start of this trial. We need individual patients' data network meta-analysis. We need real-world data using the usual matching technique, but specific to South Asian population. We also need RCTs comparing different glucose-lowering agents as add-on to metformin in South Asian population. And we do need cardiovascular outcome trials specifically in South Asian populations in order to be able to choose what the best treatment in a population that is already at a higher risk of cardiovascular disease compared to white European, despite younger age and less obesity. However, I think when choosing the second-line agents, whether it's GLP-1 receptor agonist or SGLT2 inhibitor, or for that matter, any other agents, while GLP-1 receptor agonists might currently have the slightly upper hand in terms of the data, but the situation is not definite and is not clear. What is more important is that whatever you start with the agreement of the patient get escalated if the treatment is not working or the treatment target is not achieved. In other words, probably more important than the actual choice between the two classes is combating the clinical inertia and escalating the treatment to overcome this clinical inertia is probably more important than just choosing a particular class. And with that, I'll finish here. Thank you very much for listening.
So thank you very much for going through all the evidence with the SGLT2 inhibitors and the GLP-1s in South Asians. One question I had was that we know from quite a lot of the research that Kamlesh and others have done, there is quite a lot of clinical inertia when it comes to treating people with diabetes. So should we actually be thinking about combination treatment, maybe with metformin plus SGLT2 inhibitors or GLP-1s immediately, or both GLP-1s and SGLT2 inhibitors?
So thank you for the question. Yes, I think clinical inertia is probably more important in my mind, actually, more important than choosing an SGLT2 inhibitor or a GLP-1 receptor agonist. As long as the treatment is escalated, then appropriately, then doesn't matter which agent based on the current data till we have better data. Having said that, combination treatment, whether they produce better cardiovascular benefits is remained to be seen. However, the data certainly suggests that combination treatment is very favorable. The downside to that is money. So it's more expensive treatment, obviously, to use combination.
Absolutely, absolutely, that's right. But thank you for that answer. I hope everyone heard that. The summary of that was that it probably doesn't matter which one you choose, but combination is probably a really good choice. But I think now, because of the problems with connection, thank you very much again to Ab, but we're going to move on to the next session. So I shall hand you over now to Kiran Semi, who is chairing the next session.
Thank you very much, Sarah, and I hope that everybody's able to hear me. We have had some technical issues. It's a pleasure to be here this afternoon. I'd like to introduce Dr. Sridevi Kailadini, who is a consultant psychiatrist and a previous Associate Medical Director at the South London and Maudsley NHS Foundation Trust. She's also a visiting senior clinical lecturer at the Institute of Psychiatry, Psychology and Neuroscience, and currently a clinical lead for the mental health rehabilitation for the Getting It Right First Time programme with NHS England and Improvement. This afternoon session is going to be focusing on COVID-19 and a specific focus on ethnicity and mental health. So welcome, Dr. Kailadini, and I'd like to hand over to you.
Thank you so much, Dr. Somi, and thank you so much to the organisers, the tech team. You've all been fantastic. What a fantastic session you put on for all of us. So thank you for that welcome. And so to start, this is such a huge issue, and I'm going to cover some of it in half an hour. And clearly, anybody who has further interest, very welcome to contact me to have further conversations about this and how you can get involved as well. So the first thing to say is what I'm going to be covering is firstly what differences are there in mental health linked to ethnicity in the UK and why do we see them, and how has COVID-19 impacted differently linked to ethnicity, and then lastly what practical steps can we take to bridge the disparity of health and life outcomes of those from ethnic minorities. So the differences that we find in ethnic inequalities in severe mental illness are linked to both the experiences and the outcome. And Professor Kambui, who's been studying this for a lifetime and continues to do so, has looked more recently at 28 studies, actually in September 2019, and what he and his team found was that there's increased rates of schizophrenia according to race, and that in England can be increased by a relative risk of 5.72 in Black Africans, in Black Caribbeans 5.2, in South Asians by 2.27 relative risk compared to the white local population. And interestingly, for the first time, also looking at sort of other white ethnicities. Just to reiterate then, Professor Kambui and his group have been studying this for a long time, and what they have found is that for ethnic minority groups, and this is using 28 studies published in 2019 in September in Psychiatric Epidemiology, that Black Africans have a relative risk of 5.72 compared to the white indigenous population. Black Caribbeans 5.2 increased risk of schizophrenia, and South Asians 2.27 relative risk. And for the first time, they also looked at other white ethnicities as compared to the indigenous white population. And they also had an increased risk of schizophrenia at 2.24 relative risk. So they also found that for other psychoses, although the relative risk was a little bit lower, and when we try to understand some of the other experiences, we know that there's more coercive care for this group of people, often more detentions under the Mental Health Act, much more involvement in terms of the criminal justice system, and also they get referred less often for talking therapy, psychotherapy. They are much more likely to have higher doses of medications and also to be in locked settings as well in the mental health system. So some of the explanations are cultural variations in assessment, so not really understanding when people are describing what their experiences may be. So for example, that could be somebody from South Asian background describing a lot of somatic symptoms, so that they may position their illness in their bodies rather than an emotional experience. And then thinking also about different care practices, how acceptable they are to people of different ethnicities, and even the construction of illness and recovery. So we know very often that people from different cultures, and from including South Asian cultures, may put down certain experiences not to mental illness, but to perhaps spiritual or religious. So it's really about how we work with individuals and their families to make a construct that works for them and enables them to receive the right kinds of treatment. They often have more complex presentations as well. And then all sorts of issues about trust, issues with communication, particularly if English isn't their first language. And we know, for example, that when we interview people in their first language, when it's not English, we are much more able to get to their phenomenology. Whereas if we interview somebody in English when that's not their first language, we are likely to miss quite a lot of the psychotic symptoms. So the huge issue also that I think doesn't get talked about enough, it is more so now, is racism and discrimination, and how over time that's cumulative in terms of the stress that people undertake, the anxiety, depression, which then can escalate into more severe mental health problems as well. So Howes and Murray have established this integrated socio-developmental cognitive model, which really looks at what the genes are leading on to developmental risk factors and also cognitive, motor and social impairment, and how over time those issues, including social adversity, can lead to various types of mental health conditions. And as you don't treat some of them, so the anxiety and depressive symptoms may start off initially with somebody's experience, and if that's not picked up early, treated effectively, then that can lead on to a sort of building into social withdrawal and then also subjective cognitive changes. So for example, becoming more paranoid, and that can then go into prodromal symptoms of psychosis and full-blown psychosis. The social adversity really must not be underestimated. And what are we talking about when we say social adversity? We're talking about deprivation, disadvantage, discrimination, and racial trauma. So this idea of racial trauma is something that is really building in the literature, in our clinical practice as well. It's not something that we routinely would have asked about when we talk about the different kinds of trauma, and including for children, adverse childhood experiences. But now we are really recognizing that we must ask about this because it has an incredible impact on people and their mental illness. And of course we know, and we've been hearing about some of that today earlier, that it's not just mental illness that is differently impacted by ethnicity. And here are the maternal mortality rates for England. The data is 2014 to 16, and you can see here that there is a disproportionate number of women who die during or in the 6 weeks after delivery, the postpartum period of time. And you can see there Asians, 15 per 100,000 maternal deaths as compared to 8 in the white population. And Sir Michael Marmot, who has pioneered this work and has been commissioned by many a country's government to come and have a look at what they can improve, it's very clear that health inequalities and social determinants of health are the main issue when we come to health. And I think that's really important for all of us in our medical practice to understand. We can prescribe medication, we can give other kinds of treatments, but if actually the person who's sitting in front of you has such inequalities in their life, whatever we do is going to be very minor compared to that. So what are the drivers of health inequity? Structural discrimination, and for example, many of you will have heard of the black medical student who found that when he was looking at dermatology texts, he couldn't recognise any of these rashes and so on in relation to black skin. And clearly we're all taught using a particular framework through the sort of white lens, and that impacts on how we can diagnose and of course then treat in a timely fashion. So also income inequality and poverty, and that all of this leads on to huge disparities in opportunities and disparity in political power, and also governance that limits meaningful participation. And certainly, you know, in the NHS, we all know this concept of the, you know, snowy white peaks. And it really is that issue of, if you're not of that particular group in society, you may well not understand their experience, and that means you don't think about it, you don't ask the right questions, and all of that translates into policy and services that do not meet the needs of ethnic minorities. And when we talk about structural inequality, so many aspects to that. It shows up every single place in people's lives, and that is something that they are having to struggle against just to get to the status quo. And the other aspect of this is, when we talk about institutional racism, it's not about individuals. It very much is that systems are set up in a way that impacts and is racist. So anybody turning up to work in those situations is in effect maintaining those practices. So what's happened in people of black, Asian, minority ethnic groups with COVID? You will all have seen the reports that have come out about the disproportionate deaths in people of BAME origin. And we know that the overrepresentation is multifactorial. It's likely to be lower socioeconomic groups, partly that multifamily way of living and generational households as well, and also being employed in very frontline type of work. So there's key worker roles, so far greater exposure to the virus, and a significant amount of comorbidity. Obviously we're talking mainly about diabetes here today, but there are many others, including obesity. So this really just shows some of that in a more divided manner. And I'm not going to go through all of this in detail in the interest of time, and you can of course have these slides. I must thank Dr. Raj Mohan, who has produced some of these as well, in his role as the presidential lead for race equality at the Royal College of Psychiatry. So you can see very clearly here the rates that were found by Public Health England. So Bangladeshi people were highest of risk, but other ethnicities were too of death. And in terms of thinking beyond the healthcare sector, these kinds of health inequalities are absolutely enormous. So if you add those two together in terms of lost productivity plus welfare costs and less taxes, you're coming up to about 60 billion annually. So not only is it the right thing to do to tackle inequalities, but from an economic perspective and a legal perspective, absolutely paramount. Yeah, and I'm really liking some of these comments that are coming up here in terms of collectively voicing that poverty matters. Yeah, and it's all those inequalities actually, and what COVID has done is shone a huge light on it, People are dying all the time because of these inequities, but now it's being counted and reported in a very public manner. So what practical steps can we take to bridge the disparity then for this group of people from ethnic minorities? For many years, a huge amount has been put in place, many reports, many from all across, in terms of public health issues, in terms of thinking about what you can do with the workforce, but really not enough has happened. So can I just check tech? My slides have gone. Ah, thank you. Yeah, okay. I'm having to use two devices. So back in 1965, the UN proposed the International Convention on Elimination of All Forms of Racial Discrimination, and the UK actually signed up in 1969. And what this means is every 4 years, all countries who've signed up report back in a written form on what they're doing, how far they've got in terms of eliminating racism. But because of COVID, they've cried off this year, and the next report will be due in 2022. And also we have the Equality Act, and the public sector really has a duty to hold up the Equality Act and really be a sort of shining beacon in theory for this. So the other things that we can do is culturally adapting our services and also our interventions. And as just one example, we know that for psychological interventions, that where they're not culturally appropriate, people from different ethnic groups, their outcomes are less good. And that is in relation to some of the frameworks that people use to think about illness and to think about how to get well and stay well. And then also making sure that staff have an understanding of this cultural competency, and also that they can put this into action so they have a good capability. And then thinking about how one transforms an organisation. And all of these, I'm not going to go through all of these, they're listed there. But one of the things I will say is that the Royal College of Psychiatrists, so it started really with the rehab faculty, of which I'm part, and when we were looking at our medical curriculum, we thought that really, especially given all of the Black Lives Matter issues that really brought to light all those aspects that we already know about, our curriculum has to change. The sort of whitening of all of our curricula, including of our children's curriculum, means that racism is allowed to continue because the contribution of all of these other ethnicities is not known in full, and it's not celebrated as it should be. And I'll give you another example. As the executive of the poppy factory, it came to light for me, and I was very ashamed of this actually, that I hadn't understood the whole role of Indian soldiers in the world wars. And at the centenary, this was celebrated, a special khadi poppy was created, and as a result of that, what we have decided to do at the poppy factory is make sure in the new building, which is just being rebuilt, we will have a specific area for soldiers of the Commonwealth who fought for Britain and have helped to keep this country a free country. This kind of information isn't known about, and it just adds to people's biases and perception of people from ethnic minorities. So now the curriculum for all psychiatrists who are training, it initially started in the higher trainees, but we've pushed for it to go through to core trainees as well, that they really must understand issues of racism, including structural racism, and how it impacts not just on them and their colleagues, but also how it impacts on the care of treatment from ethnic minorities. So there's lots of other work that's been going on. This is a particularly interesting piece of work on thinking about how to advance mental health equality. And this group looked at 128 studies, and I'll pick out Dr. Shubaladi Smith there, who is the other presidential lead at the Royal College of Psychiatrists for race and equality. And what they found was that a lot of these studies looked at addressing socioeconomic factors, excuse me, and race disparities, age-related issues, particularly for children and young people. And one of the main interventions was around providing psychological support and also delivering education and training as strategies. However, some of the barriers to the interventions to address these inequalities came up as a real issue. So it is about understanding what some of those barriers are so that everybody involved in healthcare can think about how to change service provision and reduce those inequalities of access, treatment and outcomes. So I can't let this go without speaking about the impact on staff from ethnic minorities. And many of us will have lost colleagues in this pandemic, if not even, relatives, friends. And as this all started unfolding, the president of the Royal College of Psychiatrists at the time, Professor Wendy Byrne, commissioned Dr. Ananta Dave to pull together a working group, and say, look, what is happening here? We need to understand it. We need to deal with it. It's not acceptable. And the working group came up with some very interesting information, and I would, any of you who haven't read it, please do. It is very pertinent to all of you working in health. But really it was thinking that some of the key factors linked to the RES questionnaire and information, what it was showing is that BAME staff are less likely to raise concerns, for example, around PPE. There may be some discrimination around, they say, the fit testing to make sure the PPE would fit properly. So for people who maybe have beards or turbans, for example. Also that there was a fear of being reported if they raised concerns around COVID, and also fear of, as a result, asking for safer work alternatives. There was an adverse psychological impact as well, isolation at work, experienced through bullying and harassment, and potentially less involvement in organising rotas and kind of making decisions about where they would be working, and also reduction and less likely in being able to call out inappropriate practice. So all of this led to this increase, as well as some of those other underlying inequalities that we've already spoken about, of deaths from BAME staff. And the really incredible thing about this, it didn't come from anybody else. It came through the Royal College of Psychiatry once this was recognised, and these recommendations, which include a risk management tool that all staff, particularly BAME staff, must go through from their employers, and I hope all of you working in England certainly have, to ascertain whether they are low, medium or high risk from COVID. And as a result of that, to make sure that the work environment is rightly reorganised to minimise risk for staff. And there was a second paper as well, which talked about other aspects of what should be taken forward. And again, I'm not going to go through all of this in detail, but would again urge you to read this, and I have, the slides share much of this information too. But it was really about learning how to protect and support BAME staff. We have to record ethnicity. We still don't do that well enough. And even thinking through my NHS E&I work that I'm doing at the moment, it's very difficult to get specific ethnicity information about things like mortality even in the mental health system. It's as basic as that. So if we're not measuring it from that perspective, how can we even surface the inequality, let alone do anything about it? So really important. Thinking about when staff are getting differential attainment, how can we support that? How can we help people who wish to go into leadership roles to move through those systems? Because when you have people who reflect our society at the very top, then issues that pertain to their particular ethnicity are much more likely to get picked up and dealt with at a systematic level, and deconstruct some of that institutional racism that currently everybody in England from ethnic minority background finds himself at the receiving end of. And also supporting psychiatrists. We do have a fantastic psychiatric support service which is available. It's a phone line rather, 24 hours. But does that really help enough for our BAME colleagues? So we talked about the training, and this is really about getting our own house in order, but this needs to be really widespread. And we also talked about using a much more experiential approach, using simulation training, and also using very diverse training materials, from the films to watch, books to read, because people really need to understand the impact. And I think just sitting in a room for an hour or clicking through your online equality and diversity training doesn't cut it. We talked about representative leadership and more research. I'm really heartened to see all this research in diabetes around what works for people from South Asian background. Absolutely brilliant. We need to do that across the board, including in psychiatry. So I will just finish here with the great picture here of Dr. Shubhaladi Smith and Dr. Rajesh Mohan, who some of you may know, a NIMHANS trainee who moved to the UK many years ago. They are together the presidential race equality leads, and they are taking forward a lot of the work I've just been speaking about, both for the college but much more widely in society, including through the all-party health parliamentary group, to try and reduce these inequalities linked to ethnicity.
Thank you for that. That was really informative, and it's been a real breadth of information you've shared throughout the research papers as well. So thank you for your time. There's just been a couple of questions that have come through at this stage, and I think the audience is in agreement around ethnicity in the wider is absolutely vital. And I think Professor Kiran Patel also made a point earlier in one of the earlier presentations that it must be essential now for that ethnicity data to be collected, given the impact that COVID has had. So there's a question around how can we use population health management approaches to ensure we can prioritise reductions in health inequalities post-COVID?
Okay. So I didn't hear the whole of that question, but I think you're saying how can we use population health data to look again post-COVID and what the main actions or the priority actions could be. So I think the first point is really collecting the data, look at the ethnicity and the disparities in terms of outcomes in all sorts of health areas. And then thinking about what the underlying reasons are for those disparities, and then trying to have quite systemic and structural responses to how we deliver our services. Looking at what protocols are in place, what processes are in place, and making sure that they all have an element of how do you use a way of looking at the access to improve it for this group of people. So if you think that these inequalities drive poorer outcomes, it really is about making reasonable adjustments that are appropriate to help people get through the system and improve their outcomes.
That's fantastic. Thank you so much for that. Well, once again, I'd like to thank you for your presentation this afternoon, and I think we're on time. And now I'd like to welcome Professor Vinod Patel, and over to you for the next session.
Thank you very much. Thank you very much, Kieran, and I really enjoyed that talk from Sridevi. Really enjoyed it. So it's my great pleasure to introduce you to Professor Philip Newsome, who looks after the metabolic services at the QE Hospital in Birmingham. He has a fantastic array of papers in this field, and I'm really looking forward to his talk on non-alcoholic fatty liver disease. So without any further delay, I'd like to hand over to Philip, and I really look forward to your talk. Thank you.
Thank you very much, Vinod. Great. Okay. So, and I think there's been a lot of recent innovation, both diagnostically and therapeutically, which I think will be of particular interest to you. So what I wanted to do first of all was really just touch on what I think the burden of NAFLD, NASH and fibrosis is in patients with type 2 diabetes, then talk a little bit about new ways in which we can identify these patients, in particular those with advanced fibrosis, and then talk a little bit about the therapeutic landscape. So the first thing to say is there's quite a lot of acronyms and abbreviations, and the term non-alcoholic fatty liver disease, or NAFLD, really captures the whole spectrum from mild indolent steatosis as indicated here on the left, all the way through to those patients developing advanced fibrosis and cirrhosis. Now, in between those two, you've got this entity called non-alcoholic steatohepatitis, and that's really when you start to see not just accumulation of fat, but when you start to see liver cells being damaged by the deposition of fat and the immune reaction. The other point to make is that you've got two things. You've got the inflammatory damage that results because of the fat inside the liver, and then secondly, you've got the fibrotic response to that. And there's almost a sort of frame shift, because it's only the vast majority of patients with NASH will not necessarily have advanced fibrosis, and that really starts to kind of kick in later on, as you can see here. So really the way we grade fibrosis is 0 to 2 is kind of mild, perhaps moderate. F3 would be bridging fibrosis, which we would consider advanced, and obviously cirrhosis, whether it be compensated or decompensated, is more significant. So how do these patients present? I think the first point to make is that, like most liver conditions, patients with this condition don't present with overt liver-specific symptoms, unless in that very rare exceptional circumstance they're presenting with liver cirrhosis, i.e. right at the end. So in fact, most of these patients come to light because they're having bloods for other reasons, and you'll see an elevated ALT, AST or gamma-GT, or you might be doing an ultrasound scan because they've got some vague abdominal discomfort, and the report will come back saying fatty liver. So this is a study that we did a couple of years ago, read by Richard Lilford, and then myself and Matthew Armstrong got involved, and we looked at the various reasons why GPs were checking liver bloods. And this excluded patients where there was an overt history of liver disease. So it's just trying to understand what the reasons were. And you see here that very many of the reasons related to review of diabetes and or related conditions, so diabetes, high blood pressure, vascular review, or dyslipidemia review. A couple of sort of vague, non-specific routine bloods or generalized fatigue. So the point to make here is that most patients are identified as having NAFLD for other reasons. It's not often the primary reason why that test is triggered in the first place. So if we go to one of the questions that comes up really is, should we be screening or should we be undertaking case finding in high-risk groups such as patients with diabetes or obesity? And that remains a contentious area. Suffice to say, at this point there's no consensus, and I would argue we need the data on cost effectiveness before we can mandate that all patients with diabetes have an annual bespoke evaluation for liver disease. The reality, of course, is many of them will have had identified already abnormal liver bloods, and that's the mandate to do something about it. So what are the baseline figures like? This is some Markov modeling from Zove Younossi and colleagues. They've got data for the US, but these are the big 4 European countries. So the first point to make is that NAFLD, in terms of the all-comers, is pretty common. So approximately 50 million people in the UK will have that. If you look at some of the data from diabetes cohorts, it ranges between 50 and 70% of patients with type 2 diabetes will have NAFLD. If you then go down the column, what you can see is that the numbers start to drop as you get into more and more significant liver disease. So, for example, if you home in on people with NASH and advanced fibrosis, that's F3 or bridging fibrosis, you're down to about 300,000, which is about 0.5% of the population. And then as you get to cirrhotics, you're down to 100,000, and then decompensated cirrhosis and the like. So I think that's an important message, because although NAFLD is very common, in fact, these are the patients that from a liver perspective we're trying to identify. So this is a study from Steve Harrison, done in a US barracks many years ago, and it enrolled not just soldiers but also their dependents and people that were retired, and it looked to try and understand the prevalence within that cohort of NAFLD. So 400 patients enrolled. I mean, this is Texas, so the BMI was 30. About 1 in 7, 1 in 8 had type 2 diabetes. And you'll see that initially they had a screen, they had an ultrasound scan, of which just about half had a fatty liver on ultrasound, and they offered biopsy to all of those patients. It is Texas after all. You'll see that the majority of them accepted the biopsy, and of those you see that about 40 out of 134, doing the numbers, had NASH, of which 9 had advanced fibrosis. So it's an example of real-world-ish data as opposed to Markov modeling. And the other point, again, just to make here is, firstly, the variance across different ethnicities. Again, obviously it's Texas, so the ethnicity was more around Hispanic and African American. And here you are. So 3/4 of the patients had type 2 diabetes had NAFLD, and 1/5 had NASH. So that's probably an overrepresentation compared to the general population. So the bottom line is it's commoner in diabetics, and we're drilling in on that sort of 0.5% of the population which has NASH and advanced fibrosis. So why do I keep going on about fibrosis? Well, the answer is that fibrosis predicts mortality. Okay, there's two graphs here. The one on the left is a systematic review of meta-analysis we performed recently, and it looked at all the published trials and studies. It looked to try and understand the relationship between the degree of fibrosis. Remember, 0 is nothing, 4 is cirrhosis, 3 is bridging fibrosis, and your absolute risk of mortality. And as you can see here, there's a reasonable linear link once you start to develop fibrosis as you go up to F4. Okay, that's all-cause mortality. And I bring your attention to the absolute risk here, because when you skip over to the right, you'll see that this is liver-related mortality. The numbers are all a bit lower. So the first message is that the commonest cause of death in patients with NAFLD is vascular disease. The second commonest cause of death is non-liver cancer, and then you get into liver disease. Now, of course, that will skew. If you take a cohort of patients with liver cirrhosis due to NASH, you're going to get a slightly different readout. But in terms of all comers, the message really is we need to make sure that we manage the metabolic elements as well as we can. And if you come back here to the liver mortality, you see that it really only is when you get to F3 and F4 that you're starting to see a substantial uptick in the relative risk of dying from liver disease. So it's 7-fold versus 11-fold. So I've talked about fibrosis being the thing that we need to look for. It's not just NAFLD, it's NAFLD and fibrosis. Well, how do we find that? We're not going to biopsy everybody. No, we're not. We don't need to. The good news is that there are some very simple, cheap, essentially they cost zero because it's routine bloods, algorithms you can calculate. The very simple AST to ALT. It's been around for donkey's years. That ratio flips. As people start to develop fibrosis, it starts to increase towards the AST. But probably the best ones are the FIB4 and the NAFLD fibrosis score. If you just Google them, you get the algorithm and you can just punch the numbers in. And what these do, these allow you to basically, the greatest value is their negative predictive value. So if you were to take a patient with an abnormal liver enzyme, if their score is low, you can reassure them that their likelihood of having advanced fibrosis is really quite low. The problem is that their positive predictive value isn't great. So we're really moving towards having two tests, a kind of rule-out test, which is this algorithm, and then a form of rule-in test. So one of these is the serum ELF, which contains three components which measure elements of fibrosis turnover in the bloodstream. And that's a second sift, if you like. And then the people that are still, you can't reassure, are the ones that really need to come up to hospital for evaluation. The sort of things that we do in hospital, but this of course could be done anywhere really, is the FibroScan device. That measures liver stiffness, which we interpret as a guide to liver fibrosis. We've also got MRE, so magnetic resonance elastography, which is more of a research tool. I think the point to make here is you can see that even within the liver, it's not homogeneous. There's quite a lot of variety, as indicated in the color scheme here on the right. So you can see why a kind of an aggregate value might give you a truer reading as to the overall burden of fibrosis in a patient. So here's an example of a pathway that's been started in London a couple of years ago in conjunction with the CCG and also the Royal Free Hospital. So, the conventional history and examination, FIB4, that algorithm I talked about, so low risk, you go into this bucket here, reassure, high score, go straight to see the hepatologist, and in between, you do the second test, the ELF, to further triage them. So what does that look like? Well, actually, it's quite encouraging, because what you see is that of 1,500 patients, 1,000 of them can be reassured with no further testing. What I often saw in primary care was this, religious retesting to see if a blood test would normalize without actually making a decision. This enables you to make that decision. So of the remaining third, you can see that a small number went straight to high fibrosis and needed to be seen by a liver team. And then the rest split roughly 50-50 on the basis of the ELF. And we're in the process of trying to see whether we can implement something along these lines in an automated manner in the Birmingham region. And the consequence of this pathway is that if you took 100 referrals before, the white bars being before, 92 of them were ultimately deemed to have low fibrosis, only 8 advanced, of which 6 had cirrhosis, whereas under the new one, you've managed to markedly enrich it. Clearly still way to go in terms of trying to perhaps reduce further unnecessary referrals, but it's moving a large step in the right direction. So other ways that are potentially interesting in identifying the at-risk NAS patient, and this might be relevant for 2 reasons. One is for clinical trials, but 2, as therapies start to come online, identifying that risk group who will be the one that receives what may be actually quite expensive medications, tools to do that are of value. So we've generated a score with EchoSense. This is a UK study with international validation, which basically tried to identify patients not just with NASH, also significant fibrosis, but also significant ongoing inflammation, which is a scoring scale for that. And the way we did that was we used the FibroScan device, which gives you readouts of liver stiffness, fibrosis. It gives you readouts of steatosis using the controlled attenuation parameter, and also the serum AST. And we went through a whole number of different parameters, and these are the three that came out. And what you end up with is you get a number in the end. Essentially, there's two, I think with all these algorithms, I think they work best with two cutoffs. A low cutoff, so below that you can rule out, a high cutoff that you can rule in. In other words, you can confidently assume they have that, and that middle group where you still need further investigations. And with this, we were reasonably happy that we were able to categorize a large proportion of patients as having this advanced fibrosis and inflammation or not. So finally, just coming on to treatments, one point to make is that there are no licensed liver-specific therapies for fatty liver disease. I talked earlier about the importance of optimizing the metabolic syndrome. That's clearly critically important, and that's something you will obviously be very, very comfortable and familiar with, and the ways to do that. Treating really the root cause of obesity remains important, and I'll touch a little bit on this and in the discussion on ways to do this. Suffice to say that enabling people to lose weight and remain at that low weight is clearly very challenging, because we live in an environment which by and large is obesogenic. There aren't a huge number of weight loss medications in their own right, but we can touch on those, and of course bariatric surgery. There have been two medications which have been shown in sort of late phase 2 to be effective, but they have caveats, and that's vitamin E and pioglitazone, which you'd be familiar with. So this is one of the studies, probably the best study, that looks at lifestyle change or weight loss in the setting of patients with NASH. So all these patients had a biopsy at the beginning to confirm that they did have NASH. It was a one-arm study in Cuba, and in essence there was three components to the intervention: calorie reduction, moderate exercise, and a behavioral session. So sort of something you could deliver on the NHS, but maybe not completely. So this treatment or this package took place over a year, and what you can see here on the right is something that you'd not be surprised to see. So out of the 300 patients, okay, the mean loss was just over, so just under 4%, but actually 2/3 of patients were not able to lose 5% or more. So even in a study, even in Cuba, 2/3 of patients were not able to lose 5% of their body weight. And of the third that did lose more than 5%, that split roughly equally between 5 to 7%, 7 to 10, and greater than 10%. So there we go. So what does that mean? Well, the good news is that losing weight has an effect on inflammation in the liver. So you can see here that actually of the patients that lost more than 10%, 90% of them no longer had that inflammatory liver injury. So that's very encouraging, because it means you can set patients targets which are not wildly unrealistic, rather than say normalizing their BMI. But what about fibrosis? I've talked about inflammation, but I've also said that fibrosis is critically important. Well, I think these data start to give us an inkling that actually it can have an effect on fibrosis as well. So again, if you spin to the right and you look at the weight loss of greater than 10%, what you can see here is that of those patients, 80% had an improvement in fibrosis by at least one stage. Remember that 0 to 4 scale. 20% stayed the same. If you lost between 7 and 10%, it was 50-50. And it's only really when you get to the less than 5% or in between that you're still seeing a few patients worsening, although the rest are kind of stable or improving. So it gives us some confidence that that might be a therapeutic or an important part of the package. So there are no licensed treatments, but there's a myriad of different therapeutic approaches being taken here. Suffice to say, Big Pharma are really diving into this. There's been a huge amount of investment. The targets, are manifold: metabolic ones, anti-inflammatory, anti-fibrotic. Many of them will be drugs that you're familiar with from your expertise in diabetes. So it's a very exciting time. So I'll bring to your attention a couple of studies which I think are relevant. I think the TZDs probably do work in fatty liver disease. I think they've had a difficult press with weight gain, with bladder cancer, with osteoporosis. I think the weight gain, again, it's kind of more fluid, but nonetheless it can be a challenge. Whether they'll go through to phase 3, I don't know. There's some interesting data with the pan-PPARs which look even more effective, and I suspect that may ultimately be the solution. These are data from Ken Kusi, so an RCT of PIO in patients with NASH and prediabetes or diabetes. You'll see here that this is NAS is the measure of inflammatory damage in the liver. So the bottom line is getting PIO had a significant impact on that. Resolution of NASH, and also a suggestion, not significant, of an improvement in fibrosis. So I think they do work. I think the challenge is they're not going to get through the regulatory trials for obvious reasons. There's no farmer interest, but the pan-PPARs, I think, may be the solution. GLP-1s, however, I think that's a different kettle of fish. This is a trial that we ran a couple of years ago. It's an investigator-initiated trial run in Birmingham. Myself and Matt Armstrong, with funding from the Wellcome Trust and also support from Novo Nordisk. The bottom line was that Lyra at that highest dose of 1.8 milligrams resulted in predictable reductions in weight, improvements in ALT, and if you look here, that resolution of NASH, so going from having inflammatory liver injury to just having fat, you saw 4 out of 10 patients were getting that. It met its primary endpoint, as opposed to 1 in 10 on placebo. So that's good, but we've clearly moved beyond liraglutide. So this is the SEMA-NASH trial, looking at semaglutide. It was a 72-week trial, again looking at patients with biopsy-proven NASH. You'll see the 3 different dose arms. This was a daily regimen as opposed to the weekly regimen. Patients were up-titrated at 4 weekly intervals, so it took up to about 16 weeks to get up to peak dose for 7.4, and then they were run for the guts of a year. The primary endpoint, again, was resolution of NASH. The secondary was an effect on fibrosis. So these data are being presented at the American Liver Meeting in the next couple of weeks, but the press release is out. And what the press release shows is that 60% of patients receiving semaglutide achieved resolution of NASH. So that's the highest level of NASH resolution that's been seen with any agent thus far, compared to just under 1 in 5 patients with placebo. Now, you guys will be very familiar with the potency of semaglutide and these types of subsequent GLP-1s in terms of weight loss. So it's reassuring to see that translate into effects on liver inflammation. The other point to make, I guess, about the GLP-1s is that the benefits are not just about the liver. I said that the commonest cause of death in these patients was vascular disease. Well, the good news is that if you look at GLP-1s, there's a clear message, a clear signal that GLP-1s improve cardiovascular outcomes. And if you look at semaglutide in particular, the SUSTAIN 6 study, demonstrated for non-inferiority and superiority also being better than placebo. So I think going forward, I think that's going to be that axis of GLP-1 or GLP-1 combinations is going to be the backbone of therapy for patients with NASH. I'll talk a little bit about one drug that's been through or is going through phase 3, obeticholic acid. It's an FXR agonist, myriad of different actions on inflammation and also activating stellate cells, which are important in the driving of fibrosis. This drug is licensed for the treatment of primary biliary cholangitis. The problem with it is that you get an increase in cholesterol and you get itch, and clearly increases in cholesterol are challenging in the setting of NASH. But the interim endpoint has been reported and published in the Lancet, and what you see here is that with this drug you can see improvements in fibrosis. I mean, the deltas aren't huge, but they are statistically significant. So at the highest dose arm you see a doubling of the number of patients that achieved a reduction in liver fibrosis. There's no difference in inflammation. So it's often interesting that you can hypothesize, the different mechanisms and how they might work, but ultimately in the trials, the results come out. So this one seems to be perhaps more effective on fibrosis. There are concerns, as I said, about pruritus. So substantial numbers were getting pruritus, about 50% at the highest dose. So that is something that we'll need to think through. And similarly, alterations, on the face of it, adverse alterations in the lipid profile. Now, the argument goes that you can treat these with a statin, and therefore, in a funny kind of way, you're in an even better position because you ultimately have managed to treat that. But again, we need to see the outcomes of the longer-term outcome studies of these drugs in patients with NASH, which will look at all-cause mortality. Last couple of slides, really, just to kind of really flag up. There's a huge amount going on. So these are just some of them. The FGF analogs, again, marked reductions in liver fat with these drugs. So these modulate all sorts of things, including insulin-like actions, suppressing enzymes in the bile acid pathway. This is an interesting one, resmetirom by Madrigal. So it's a thyroid hormone receptor beta agonist, which seems to play quite an important role in the regulation of metabolic pathways. Notably, this one also reduces triglycerides. So I think it's quite interesting. And what you see here is, I don't know if you can see the numbers, but the message is that you're seeing a translation through to the impact on inflammation. So huge amount of activity and lots of drugs going into phase 3. So last slide, really just to put it all into perspective. This is the kind of time horizon of patients with NASH. The message really is that we need to find, from a liver perspective, those patients that have got bridging fibrosis and cirrhosis, because I think these are the patients that probably will benefit from additional therapies as which are coming through, whereas the ones on the left, really, it's about metabolic management, which is well in hand in primary care and in secondary care. Clearly, behavioral change is going to be critically important. The challenge, as you very well know, is how do we get this embedded and monitored in a sustainable way over very many patients. I think the pharmacotherapy is going to have to focus as a backbone on weight loss and on insulin sensitizers. And then I think you'll add on to that agents which tackle discrete pathways along fat metabolism. And there's a lot of debate. Do we do add-ons? Do we start with combinations? You know, all of this we're still working through. Finally, I think, you know, the role of antifibrotics, I think, is interesting. If you've got a patient with cirrhosis, for example, who perhaps has lost weight but still has cirrhosis, there, you know, your target is slightly different. You're trying to target the scarring rather than necessarily the upstream problems. Although in many patients, two coexist. So you can see there we combine, you know, a GLP-1, GIP with an antifibrotic as and when we find it. So just to remind you, the headline figure here is not 25% of patients, it's 0.5%, albeit probably higher in the population of patients that you look after. I've hopefully explained why it's important to tackle or identify those patients with advanced fibrosis. I've gone through, I think, a relatively simple ways of identifying those patients. I think we're still trying to work out how to monitor progression. These algorithms, we don't know as yet whether they have the precision to say for an individual patient whether they're improving or not. Yeah, and then lastly, I think we're still working through how we're going to combine, you know, the different anti-inflammatories, antifibrotics, and metabolic drugs. So I think that is everything. Thank you very much for your attention, and look forward to hearing questions.
Yeah. Thank you very much for it. It was a wonderful talk, very nicely summarized at the end. So I think we've got time for two questions. First of all, Professor Yajnik from India asks, is NAFLD related to early life undernutrition, either as low birth weight or methyl donor deficiency? Because the earlier sort of work on this was around animal models being mainly due to dietary deficiency of methionine.
Yeah, it's difficult to know. Possibly. I mean, I think the same probably holds true for obesity as well. To what extent is obesity primed by your, you know, time in utero and then your early childhood? I mean, I think the angle to focus on there, I guess, is around maternal health. And I think, you know, the childhood obesity strategy, I think, is critical, because not only does it bleed into adults, but I think if you can tackle obesity at an early age, I think you prevent that development in later life.
Thank you very much. And there's another question here. What are your thoughts on duodenal mucosal resurfacing? From Andrew Pernett.
I'm open-minded as to these things. I think, to my mind, I think that it feels, I guess until we see larger clinical trials on that, I think I'd reserve judgment. My gut feeling tells me, excuse the pun, that, you know, those approaches seem a little bit excessive for something that, you know, is an at-scale problem. And I suspect, you know, pharmacotherapy will probably be the more plausible one. But ultimately, we should be driven by the data.
And Philip, just to finish, the last one from Rashid Zaman, can you please comment on reversing NAFLD by diet, particularly around cutting down carbohydrates, processed food, weight loss, and increasing muscle mass, which is a question I was interested in as well.
Yeah, no, so there's no doubt that I think increasing muscle mass is important. I think the question as to what type of diet should you use, I'm sanguine on that. I think at the end of the day, it's about a healthy, balanced diet. and I think exercise is important. Exercise has been shown to clear liver fat. I think the greatest value of exercise is I think it reinforces dietary changes because it makes people feel better about themselves, and I think then finesses how they respond to dietary cues.
Yeah. Well, thank you very much, Philip. We'll keep to time. Wonderful talk. I learned a lot about NAFOLD, and I'll hand the chair over to Sarah Ali to introduce the next speaker. Over to you, Sarah.
Thank you, Vinod. So I just want to say that we're now halfway through the conference so far, and I want to say a big thank you to all our speakers so far, but also the sponsors, Novo Nordisk, Abbott, Boehringer, Engelheim, and all the participants for being interactive and listening. And also, surprisingly, for South Asian Health Foundation, we are running to time, which is great. So it gives me absolute immense pleasure today to introduce Professor Nita Faruhi, who's going to give us a talk about a very topical subject, low carbohydrate diet versus low calorie diet. It's talked a lot about in the media, but also social media and obesity, diabetes forums. Nita Faruhi, for those of you who don't know, I'm sure most of you do know her. She is the head of the Nutritional Epidemiology Program at the MRC Epidemiology Unit and Professor of Population Health and Nutrition at the University of Cambridge. She is a consultant as well in public health with Public Health England. Her research is renowned internationally and is part of public health policy, and her research mainly focuses on defining the link between diet, nutrition, and the risk of diabetes, metabolic syndrome, and obesity, with a focus on global health and nutrition. And for me, Nita is a truly inspirational woman, leader, and researcher in medicine. So I'm really looking forward to this talk, and I'll hand it over to you, Nita.
Thank you very much indeed for those kind words of introduction. So over to the slides, please, if possible. And while they're coming on, just to say the question is, which diet do we want to go for, low carb or low cal? And I'm going to call them carb and cal throughout. Okay, so for my disclosures, I have no financial disclosures. I do sit on a national committee which deliberates and is assessing the role of low carbohydrate diets in diabetes. So if I could see the slides, that'd be great. Okay, I'm going to use my arrows now. Perfect. So learning objectives that I've set, really, if we look at the third one, I hope you will leave with greater knowledge and less confusion than when you arrived into the session. So I have lots I want to say, and there's lots you probably want to hear, but let's hope there'll be some relevance in the middle of what I'm saying and what you want to hear. Okay, so as far as league tables go, diet is number one in risk factors for non-communicable disease, for chronic disease, including diabetes, of course. But on the ground, what it looks like is, well, what should I eat? And already questions have come in some of the earlier sessions of which type of diet. Well, there's a plethora of information available. There is no dearth of that. Everybody will give you advice on eat this or eat that. In reality, the evidence in the past has been based on the low-fat diet paradigm, based on the diet heart hypothesis. And here, of course, low-fat products and perhaps even fat-free products were promoted, which then led to lots of sugar being added to those products to make them palatable. And now we're in a situation of, well, are we eating too much sugar? And should we be focusing on low-carbohydrate diets? And calories, of course, are always important in terms of weight. So there is a lot of information. Certainly it's important, a lot of passion. People hold on to their views of which is the best diet. And dare I say, a lot of vested interests in all camps. But confusion, what is the evidence? So cornerstone of diabetes management is the management of weight. Because in a very simple way, if you look at the law of thermodynamics, when calorie intake overtakes what we expend in physical activity, we get weight gain over time with obesity and then type 2 diabetes. And we know that the connection between obesity and type 2 diabetes is pretty strong and causal. So we need to manage weight, both for the prevention of diabetes and for its further complications. So what are carbohydrates? Well, they are part of the major macronutrients, one of three. So there's carbohydrates, fat, and protein. And within these, fats provide the most energy per gram, 9 kilocalories per gram of fat, and less than half of that for each of carbs and protein. And carbohydrates come in the forms of starch, sugar, and fiber, and the energy-bearing part are the starches and the sugars. They're all broken down into glucose, and therefore that's a readily used source of energy. And what do various guidelines tell us about how much we should eat? Well, pretty much most guidelines, and this is the one in the UK from the Scientific Advisory Committee on Nutrition, tells us to aim for about half of our daily calories or energy from carbohydrates. So where do low-carb diets in this fit in? Well, it depends on what the purpose is. So let's look at diets for weight loss. And here the goal is prevention of diabetes and, of course, multiple other health benefits. So this was a great trial that was done in the United States with over 800 participants who were obese. And the investigators followed, compared 4 different diets. 2 of them were low fat with modulation of protein into average or high protein, and 2 of them were high fat, which means low carbohydrate, with again average and high protein. So let's just walk through this. On the left here, we have intention to treat analysis, and on the right, the per protocol analysis. And in both of these, we see 3 things. Firstly, in all the diets, there is, from the baseline of no weight change of 0 there is weight reduction. Secondly, over time, there's some weight regain, but still it's staying below where the starting point was. And thirdly, and perhaps most importantly, there is no significant or meaningful difference between the 4 diets that are compared. So that's a single trial, and I'm always a great advocate for not focusing on single studies, but looking at the totality of the evidence. So here's a meta-analysis. This is the world's largest meta-analysis of putting together all the evidence on different nutrient compositions and weight change. So here's the weighted mean difference in weight at follow-up of 1 year. These studies were of at least a minimum of 1 year. When we compare low-fat diet with the usual diet, we see there's a clear winner. Being in a low-fat diet gives us, on average, 5.5 kilo lower weight at 1 year. But what happens when we compare low-fat and low-carb diets head-to-head in a comparison? Well, it looks like the low-carb diet does win. But hang on, before we get too excited, look at the magnitude. It's 1 kilo difference at 1 year. Now, this is not going to make masses of difference in metabolic health. So let's just hold on to that. What about another meta-analysis? So here you will recognize there are some named and branded diets which are low carb or low fat and middle. So Atkins as a low carb one, or the Ornish or Rosemary Conley, Weight Watchers in the middle. And guess what? What would you predict that this showed? Well, the same as what we saw before. Same points. There was significant weight loss with any macronutrient composition diet as long as people stuck to it. And the differences between them were marginal. So from this, there are take-home messages which are macronutrient-based energy deficit does work. There is no single best nutrient type in this paradigm for weight loss, and adherence over time is really the biggest challenge. Okay, so let's move to diabetes. Now, we know that over time, diabetes is the natural history is that of progression from normal glycemia to pre-diabetes to diabetes, and really all the parameters we're interested in terms of glycemia and cardiovascular risk, they go in the wrong direction and beta cell function declines. The search has been on for decades on what the ideal intervention might be. So where does diet fit into this? So when the goal is management of diabetes, let's see where we are. Okay, so we would predict and hypothesize that because carbohydrates are the prime source of postprandial blood glucose, therefore going low carb is the obvious place to start for glycemic control. What do guidelines say? Well, most of the guidelines around the world, and the American Diabetes Association no exception, have told us for years that there's no ideal percent of calories from carbohydrate, fat, or protein for all people, and that we need individualized assessment, and we should look at preferences and metabolic goals. There's one difference, though. The latest one in 2019 from ADA has now included some statements on assessment of individuals and then giving individualized guidance on self-monitoring carbohydrate intake to optimize food choices. So this is new. And where does this come from? Well, there's been a body of evidence accumulating. So here are some clinical practice studies. This on the top here is showing the work, excellent work done by the group of Dr. David Unwin, who is a GP, who has done some fantastic work on in his general practice on low-carb diets. And here with 10 education sessions, this was a digital low-carb program in 1,000 people. At 1 year, there was weight reduction of about 7% body weight and lower glycated hemoglobin. And here's another clinical practice study, first one showing at 1 year results and the second one showing the 2-year results. This is a commercial program, the Verta group in the US, in a self-selected group of people. At 2 years, there was sustained effect for weight loss of about 10%. There was a reduction of glycemia of about almost 1 percentage point and reduced medication use. So this is promising, but that was not randomized controlled trial evidence. And when we look at the RCT evidence, what do we see? This is a busy slide, but let me walk you through this. Here are a synthesis of 6 different meta-analyses, and there are others too, but these ones show underlying data on a huge number of individual RCTs, up to 25 or more, in some here, 36. And they compared different proportions of carbs as energy percent at different durations. At 3 months, there was a quite convincing reduction in glycemic control in the lower carb group compared to non-lower carb group. By 6 months, this was still present, but leveling off a little bit, and the magnitude of the difference was lower. By 12 months, the differences had disappeared pretty much, almost, and by 24 months, there were no differences remaining between low carb and other carb programs. So let's look at some of the key considerations here. Low carb diets, there are certainly benefits in the short term, as I've just shown you. However, many trials did acknowledge that they were of low quality and that more research is needed. There were different definitions of how low to go with the low carb. This, in the next point, is a common problem in all nutritional trials. There are different degrees of adherence. What you prescribe and what people eat varies hugely. Interpretation, we were already touching on this in the previous conversations in the sessions. Are the effects due to low carb or are they due to high protein? And is it all due to weight loss, or are there independent effects on glycemia? What about different ethnic groups? Very little, hardly any information in South Asians. What about beyond 1 year or 2 years and long-term impact and safety? And the focus has been exclusively on quantity. What about carbohydrate quality? So let me take some of those points on. What is low carb after all? Well, there are many definitions, but this here, what I'm showing you, is a commonly accepted one. And in this framework, based on a 2,000 kilocal diet, once you start to go above 225 grams per day, i.e. more than 45% of energy as carbs, that is classified as high. So the current UK guideline would be seen as high carb intake. And at the other end of the spectrum, you've got the, sorry, let me go back, some things aren't showing here. The ketogenic shouldn't be listed here, it should be up here, right at the top, in the very low carb group, that is the ketogenic end with nutritional ketosis, only up to 10% of energy as carbs, no more than 30 to 40, 50 grams of carbs per day. And typically this translates to reducing or eliminating to different degrees intakes of all the things we all love: bread, pasta, cereals, grains, many fruits and starchy vegetables, legumes and beans, and by contrast, increasing full fat products, meat, high fat dairy, cheese, cream, butter, and animal protein. Okay, so the other point I wanted to pick up on is quality. We've talked only about quantity. Well, there are at least 4 different components of quality that matter, and not all carbs are the same because of these aspects. There's the fiber content, there is whether it is refined or whole grain in nature or the degree of processing, whether the glycemic response is rapid or slow in terms of glycemic index and glycemic load, and the food structure itself. So now we know that if you have whole intact fruit versus juiced out into fruit and certainly sugar-sweetened beverages, that gives very different effects. And what's the UK guidance? Well, it's to keep free sugars in total to under 5% of energy intake per day, to minimize or eliminate sugary drinks, to consume 5 portions of fruit and veg a day of different varieties. So it's not just 2 bananas and I don't know, 3 cucumbers a day, but variety across those, and fiber of 30 grams per day. And just one slide here to capture much of the evidence that's out there about quality. This is showing the prospective longitudinal association with fiber intake and a number of outcomes, including mortality here, cardiovascular disease, diabetes, and colorectal cancer. For all, the higher the fiber intake, the lower the risk of each of these or incidence of each of these. And finally, on low-carb diets, what about long-term effects? Well, you can't get those from trials because I don't think you or I would be willing to stay in a trial for years and years to be observed and to take particular diets. So here's longitudinal evidence. This is looking at an American study, the ARIC study, and the PURE study in 18 countries, a global framework. And here, what this is showing in a prospective analysis is a U-shaped association. And if you like, here is, if you like, a sweet spot of around 48% of energy from carbohydrates, below and above which both low carb and very high carbs are associated with increased mortality. So longer term effects still need to be studied. We don't know enough, and this is prospective evidence with limitations, and we need more. Okay, so what about if we're even more ambitious? And some of you were asking questions earlier about the role of diet and nutrition for the reversal of diabetes. So now we're getting bold. Now, there's been some fantastic work done in Glasgow and Newcastle by Professor Mike Lean and Roy Taylor, and they led the DIRECT study, and they went boldly for remission outcomes by stopping all anti-diabetic medication as well as all antihypertensive medication right at the start before going into the trial. So here they took the 1-2-3 approach, total diet replacement initially for 12 to 20 weeks, step food reintroduction, and structured support then for long-term weight loss. And here are the findings. 3 things I'd like to highlight. First, in the intervention group, a quarter of people achieved 15 kilograms or more of weight loss. Second, about 50% of people were in remission at 1 year. And third, there was a dose response. The greater the amount of weight loss, the greater the degree of remission. So if you like 30, 60, and 90% remission with more than 10, 10 to 15, or more than 15 kilo weight loss. They went the distance. They did 2-year analyses as well of all anti-diabetic medication. More than a third remained in remission. And actually, in a sub-analysis, if more than 10 kilogram weight loss, then 64% were in remission. And that is comparable to bariatric surgery, in fact. Now, this is a game changer. Type 2 diabetes does not have to be irreversible, progressive, and lifelong, unlike what I learned when I was a medical student and a junior doctor. And to pick up on Parthakar's talk earlier, we're now talking the language of reversal. We're now and need to talk the language of remission and reversal. And the background to the mechanisms of this, very briefly, are that positive calorie balance sets off these vicious cycles of ectopic fat in the liver and in the pancreas with the metabolic perturbations, and there you have the problem of metabolic disease. Here is some wonderful work in a slide from Roy Taylor that when in one person the amount of liver fat has gone down over 8 weeks or so back to normal, under 2%, look at what has happened in the pancreas. I'm sorry this particular figure has got a bit disrupted, but essentially what it's showing on the right-hand side is that over 24 months, the maximal insulin response is back to normal. Yes, you heard it correct. it's back to almost normal and comparable to those who are non-diabetic controls. So beta cells haven't died, they de-differentiated. And here they are awoke again. So in terms of low-calorie diets now, let's be fair and do similar considerations as we did for low carb. Well, energy deficit diets are effective and very effective at up to 2 years. There's a dose response in relation to degree of weight loss. It's not easy for some, but the short time horizon for the intensive diet is a winner. The total diet replacement or liquid calories, well, it's not a cup of tea for everyone, but the investigators never said that it has to be this way. Of course, alternative strategies can be used. Evidence remains sparse in ethnic groups, but I know that already there's work happening in South Asians and in different populations. Beyond 2 years, there's little evidence, but there is work happening, and weight regain, of course, remains a challenge for all weight loss. So if I refer back to what Professor Vallabhji told us earlier, the COVID-adapted pilot of the low-calorie program is now happening, and I will not repeat what he already told us earlier, but suffice to say that the same 1, 2, 3 approach, as I just told you about, is happening in this trial. There are 10 pilot sites, and I think this will contribute a lot to our greater understanding based out there in the community. So what about South Asians? Special considerations? Yes, absolutely. Limitations? We have very limited nutritional research, mostly descriptive. Why do we need more research in South Asians? Well, our types of foods that we consume are different, our knowledge, attitudes and behaviors, cultural influences, and what moves us away from eating certain things are different. But here's the true story of how much carbs we do eat. So the national UK guidance is 50% of energy as carbs and under 35 as fat and the rest as protein. Here's a UK study showing about 57% of our energy consumption from carbs, and another one in South Asia with the Pure study in the South Asian part of it showing a staggering average 65% of our energy coming from carbs. And here is data I've pulled out for you from the National UK Survey. And what this is showing is that Asians, indeed shown here in red, do have the highest carb intake, and starch is the greatest contributor to it. In fact, we do rather well on free sugars and fiber compared to white and other ethnic groups. So clearly, for South Asians, for any group, or for any group with high carb intakes, there are some clear winners, low-hanging fruit. Avoid added sugars, avoid sugar-sweetened drinks, reduce refined carbs and highly processed foods, do eat the good carbs, as in fruit and veg and whole grain things. Easier said than done, but here is a handy tip for all of us. I use this, and my family uses this all the time. For those things with labels, if the ratio of total carb to fiber is less than 5:1, it's a great choice, but there are very few options on the market like that. Less than 10:1 is good. Go for that. Okay, so finally to some myths and facts. Myth: low carb diets are more effective than low fat diets. Well, actually the collective body of evidence does not show us that. And here was a nice study from California, Chris Gardner's work. When you compare, these are individuals now, not the population average response. People in low fat diets, individuals, went all the way from 10 kilogram of weight gain all the way down to one person here with 30 kilogram of weight loss. And similarly for low carb, some individuals put on weight and some lose weight because of adherence issues. Myth: carbs are essential as energy source. No, because that's why the nutritional ketosis works, and we can use the fats as energy for fuel. But think out what you're cutting out when you don't have the good carbs. Myth: need diabetic foods for diabetes? No. Sadly, these are expensive things that are still promoted in many countries but are not needed. Myth: there is a best diet. No, there's no single best diet for all. A number of options are available, but the challenge is as I've outlined. So some other dietary strategies, we've talked about the low calorie and the nutrient-based approaches. To achieve low calorie, there's all different types of fasting that one can do. Of course, in Asia, we have had Ramadan and Hindu fasting of different types. So fasting is not new to our culture in South Asia. But now this has been more formalized for weight loss in different paradigms. The 5-2 fast diet, you've heard Michael Mosley and others talk about it. Alternate day fasting. Time-restricted feeding is an interesting one, where you consume all of your diet within about 6 to 8 hours in a day. And portion control without calorie control is another. One important area is coming up on lifestyle as medicine and actually prescribing food as a specialty drug. So this is an important area, particularly when we talk about people with limited incomes with food insecurity. And there's a lot published. We've published stuff in the BMJ. There's other stuff out there that we need to focus on foods and not processed products, and we need to look at quality. And one final thought I want to leave you with is really to say that this one has been very, very important to me in my understanding as I've progressed in this knowledge, is that diabetes is not irreversible and diet has a key role in managing that. And this personal fat threshold is very important. So it's a common myth that everyone needs to become of low BMI or non-obese. Well, actually, there's a personal fat threshold shown here in a dotted line across each of the BMI categories. As long as you move below that by losing about 15%, and if you're of lower weight, about 10% of that, then you do not have to have diabetes. So with that, I'd like to basically draw this to a close by saying wider influences are important, of course, and here is COVID, and the reality is that we've all been purchasing and consuming a lot more fat, a lot more carbohydrates, and a lot more energy. This is data compared to a year ago. And there are problems for alcohol drinking and food insecurity. And if that isn't enough, we've got Brexit coming. So with that, thank you very much.
Thank you so much, Nita. Can you hear me?
Yes, I can.
Yes, thank you so much, Nita. That was beautifully summarised and was very balanced. I think you've stunned the audience to silence. There are no questions, so thank you very much. I just wonder if we could have, do we have time for one quick question about protein, if possible? I know Professor Vinod Patel would want to ask about protein consumption in South Asians. You showed a slide that there's only 12 to 14% protein consumption in Asian diets, and it's quite a good macro nutrient in terms of satiety. What are your feelings on that?
Yes, I think we consume diets in what's called an isocaloric model, i.e. the energy is made up of carbohydrate, fat, and protein. So if you eat more carbohydrate, then something else you eat less of. And in South Asians, because a lot of our diets are also vegetarian or even vegan, we miss out on a lot of protein. So protein is very, very important for all sorts of body physiology. And there's a complicated science around the effects of protein on satiety, and in terms of how it impacts metabolic health. So protein is very important. There's virtually no research in South Asians on this. Our challenge is, as we take forward the research that, on say, the direct study in the South Asian populations, I think we need to build in there neat designs, and also we can do one-to-one trial of N of 1 with adaptive design and look at the diets with increasing amounts of protein in them in the South Asian groups. So a heck of a lot still needs to be learned about protein, and in South Asians it's hugely important.
Thank you very much for that, and I think I'll link you in with Professor Vinod Patel for his Patel plate. You might have heard of it. But thank you once again for speaking to us today, Nita. And I'm now going to hand over to good friend Ami to take over the chair for the next session.
Thank you.
Thank you very much, Sarah. So I'm Ami Banerjee. I'm a cardiologist and academic at University College London and a trustee of South Asian Health Foundation. And great to be here and to welcome our next speaker, Dr. Tom Barber, who is both Associate Professor and Consultant Endocrinologist at University of Warwick. And he runs the obesity service there and is a very accomplished academic with over 90 publications. And he's going to be telling us about novel insights in cardiovascular outcome trials. Thank you very much, Tom.
Okay, so well, thank you very much for the organisers for inviting me to give this talk. It's a pleasure to be speaking at this excellent meeting. And I'm going to spend the next 25 minutes or so discussing novel insights from recent cardiovascular outcome trials, and there should be 5 minutes at the end for Q&A as well. So if I can just click on to the next slide here. Give me a second. Okay, so the outline of the talk is shown here. I'm going to focus primarily on two outcome trials, the DAPA-CKD, the dapagliflozin and prevention of adverse outcomes in chronic kidney disease trial, and the Credence study, the canagliflozin and renal endpoints in diabetes with established nephropathy clinical evaluation. So you can see then that we're going to focus on renal outcomes, and these are two of the more recent outcome trials for type 2 diabetes in relation to the SGLT2 inhibitor class. Here we have then a summary of chronic kidney disease, and this is obviously incredibly common in our patients with type 2 diabetes. Around a third overall of patients with type 2 diabetes have some degree of chronic kidney disease, that's diabetic kidney disease. And you can see here, in terms of causes of CKD, diabetes right at the top, and then hypertension, dyslipidemia, and then we've got other renal causes, recurrent renal infections, glomerulonephritis, and so on, polycystic kidney disease, obstructive uropathies, and certain drug therapies such as non-steroidal anti-inflammatories and lithium, for example. And you can see the risk factors here, clearly cardiovascular disease, smoking, obesity, older age, and importantly for this meeting, certain ethnicities such as Asian origin. This is an important risk factor for CKD. So in terms of our patients with type 2 diabetes, if they're of Asian origin, we need to be particularly cognizant of this outcome, this long-term outcome of chronic kidney disease. It's very important. Now, in terms of symptoms, clearly, most of these patients with CKD are asymptomatic, and usually it's picked up through blood tests or urine screening. And I think it's worth pointing out at this point that really there's a lot of emphasis on EGFR, and there's a lot of, in terms of our licensings of therapies and so on, this is based on EGFR, but actually it's two sides of the same coin. And actually, urinary albumin is just as relevant as EGFR. And clearly, the two usually go hand in hand, but it is possible to have one without the other. But it is important, not to neglect albumin urine as well. This is clearly very much part of the whole disease process, and something that we obviously need to do for as well. In terms of symptoms, clearly these don't normally become apparent until uremia sets in, obviously towards the one end, the kind of more severe end of the spectrum. And you can see the features of uremia here: fatigue, weakness, nausea, disturbed sleep, reduced mental sharpness, edema, hypertension, vomiting, loss of appetite, for example. All these kind of non-specific features which thankfully most of our patients don't have, because obviously most of our patients are at the mild to moderate end of the spectrum. But it is important to be aware of these features of uremia as well. So let's look at the DAPA-CKD then, and let's look at the rationale for the DAPA-CKD. Clearly, as we've heard, CKD represents a global healthcare burden, and I would actually argue that, CKD and even end-stage renal failure, this is really of kind of epidemic proportions pretty much. If you look at over the last 20 or so years, there's been a progressive increase in the numbers of patients with chronic renal impairment and those requiring dialysis at the end-stage part of the spectrum. And so this has become much more prevalent, and clearly we're much better nowadays at managing diabetes, managing the cardiovascular risk, and keeping patients alive for longer. And so clearly the longer term outcome, like CKD, is becoming more prevalent. So this has become a very prominent part of what we do. It is a global healthcare burden. It is a big contributor to global healthcare morbidity and mortality as well. Clearly having CKD in itself is a risk factor for premature mortality and cardiovascular disease. And clearly up until quite recently, we had ACE and ARBs as the mainstay of therapy for CKD, both in terms of its treatment, but also preventive factors as well. And really that was the case for 2 decades, really, is that we've basically had that. And now all of a sudden we have this relatively new class of therapy, the SGLT2s, which is kind of causing a sea change, really, within this whole area of clinical medicine and clinical research. So when we look at the DECLARE trial, clearly this showed improvements in terms of hospitalized heart failure and renal outcomes in patients with type 2 diabetes. But importantly, these patients had preserved renal function. and they had with or without established CV disease. The DAPA heart failure trial, the DAPA HF, looked at those patients with heart failure with reduced ejection fraction, okay, with or without type 2 diabetes. So it was a specific population, and again showing dapagliflozin improved risk of worsening heart failure or death from CV causes, both in patients with and without type 2 diabetes. Now we have DAPA-CKD, which is specifically looking at patients with CKD, again with or without type 2 diabetes, and again looking at the effect of dapagliflozin on renal and CV outcomes and mortality. Now it's important to note here, actually taking a step back, is that when we had the original CVOTs in this kind of class, the EMPA-REG, Canvas and Declare, there was a suggestion that maybe those patients with moderate or worsening CKD, maybe they didn't have as good CV effects from this class of therapy. And so, now clearly those studies were not focusing on CKD specifically, whereas clearly DAPA-CKD was powered for that very purpose. So let's look at the design of the DAPA-CKD study. It had a very simple design. It was a one-to-one randomized allocation. As you can see, dapagliflozin, 10 milligrams plus standard of care versus placebo. This was a multinational placebo-controlled parallel group study in over 4,300 patients that were randomized with a median follow-up of 2.4 years. These were adult patients that had an eGFR between 25 and 75, so they were renally impaired patients. They also had urinary albumin to creatinine ratio of 22.6 to 565 milligrams per millimole. So these patients had albuminuria in addition to impaired eGFR. They were on stable maximal tolerated dose of ACE and ARB for at least 4 weeks, and as we've heard, they either had type 2 diabetes or they didn't have type 2 diabetes. It wasn't restricted to type 2 diabetes. In terms of exclusions, type 1 diabetes, polycystic kidney disease, and immunosuppressive therapy as well, and various other types of nephropathy such as lupus and ANCA associated, for example. Now, in terms of the primary outcome, you can see this is a composite outcome of sustained at least 50% eGFR decline, end-stage renal disease, renal or cardiovascular death. That was the primary composite outcome. In addition to this, there was also secondary outcomes, a renal composite of at least 50% eGFR decline, end-stage renal failure or renal death, and a composite of CV death or hospitalized heart failure and all-cause mortality. So let's have a look then in terms of the baseline characteristics. You can see immediately that the two groups were very well matched across all of these different criteria. The mean age, 62. 1/3 were female. In terms of the ethnicity, just over half were of white ethnicity, and importantly for this meeting, around 1/3 were of Asian origin. So a substantial minority of the patients within the DAPA-CKD were of Asian origin, which obviously is useful in giving us evidence for this important population group. In terms of type 2 diabetes, about 2/3 had type 2 diabetes. Okay, so this, as we said earlier, it's not exclusively type 2 diabetes study. The systolic blood pressure, you can see, 137, and the mean eGFR 43. So again, consistent with the design of the study, and as we said earlier, this is specifically in patients who are renally impaired, consistent with that, mean eGFR of 43. And again, during albumin to creatinine ratio, you can see there, average 109 milligram per millimole. So these had severe albuminuria, and as you would expect, the vast majority, 97% on ACE or ARB. So that's the baseline criteria. Now then, let's look at the main outcome then from the DAPA-CKD study for the primary composite. Remember, sustained at least 50% eGFR decline, end-stage renal disease, renal or cardiovascular death. You can see here the substantial reduction, this relative risk reduction of 39%, and this astronomic p-value. You can see that you don't normally see that kind of level of significance in biological studies. It's normally kind of astronomy in some way you see that type of p-value, but highly significant outcome here, this primary outcome of this primary composite outcome. So let's break down then the various components of the primary outcome. So you can see here on this forest plot at the top there is what we've just shown. It's the primary composite outcome, as you can see. You can see the hazard ratio there, 0.61, and highly significant. Then when you look at the further down this forest plot, the components, at least 50% eGFR decline, You can see end-stage renal disease, eGFR of less than 15, and chronic dialysis. You can see all favouring dapagliflozin, all remarkably consistent. Okay? CV death, you can see there, wasn't quite as relevant. It was actually not significant, as you can see from the p-value. But in terms of the renal composite outcomes, this was highly consistent, and it seemed to be all of the different renal components, at least, were kind of pointing in the same direction. In terms of other salami slicing, in terms of, for example, type 2 diabetes versus no type 2 diabetes, urinary albumin to creatinine ratio with a cutoff of 113 milligrams per millimole, eGFR cutoff of 45 above and below. You can see it doesn't really matter how you kind of divide the data. The data pointed to the same thing. In other words, superior or improvement for dapagliflozin versus placebo, significant improvement in terms of the renal outcome. This is a really important learning point from this study. Okay, so it's not just the effects are not just confined to type 2 diabetes. In fact, it doesn't matter if you have diabetes or not. You will still get renal benefits from dapagliflozin, as you can see. Again, in terms of the urinary albumin to creatinine ratio, it doesn't really matter where you are on that spectrum. You will still typically get benefit, and ditto for the severity of the eGFR as well. This effect appears to be maintained regardless of the severity of the renal dysfunction. So let's look at then the treatment benefits across pre-specified subgroups. Again, when we look at age, for example, with a cutoff of 65, male versus female. When we look at ethnicity, and we look at geography, so continental region, and blood pressure. Again, it doesn't matter how you slice up these data, it's pointing in the same direction, favouring dapagliflozin. And you can see the heterogeneity score there, non-significant. So in other words, these are kind of consistent effects, regardless of how you slice up the data. And importantly, obviously, again, for this meeting, when we look at the Asian group, there's really no difference in compared with other ethnicities. There appears to be a consistent effect here. You can see in terms of the systemic effect, there may be some difference there, but importantly, it's still consistent. It's still to the left of the midline. It's still favouring dapagliflozin. So let's look at the secondary composite outcome then. And this is the secondary renal composite, which is very similar to the primary, but without CV death. So in other words, sustains at least 50% eGFR decline, end-stage renal disease or renal death. Again, as you might expect, highly significant, this time relative risk reduction of 44%, as you can see. And then when we look at the secondary composite outcome of CV death or hospitalization for heart failure, again, significant results favouring dapagliflozin with a relative risk reduction, this time of 29%. And this is important clearly because we're not just looking here at renal outcomes, we're looking at cardiovascular outcomes as well. In this case, the composite of CV death and hospitalization for heart failure, as you can see, significant improvements. This is important because remember, this is a renally impaired population, most of whom had type 2 diabetes, but a third didn't. And in this group, you can see with dapagliflozin, there was a significant improvement in this cardiovascular composite outcome, secondary outcome. So in terms of the statistical significance achieved for the primary and all secondary outcomes, this is summarized here. So we've mentioned earlier the primary composite outcome on the top here. Remember the hazard ratio 0.61, highly significant. The three secondary outcomes, the renal composite, as we've heard, the composite of CV death and hospitalized heart failure, and the all-cause mortality, you can see all favouring dapagliflozin, consistent results. So what about the safety outcomes from the DAPA-CKD study then? Just to orientate you to this slide, you can see on the left side the safety outcomes, and in the middle row the results for dapagliflozin, of which there were over 2,100, as you can see, and a similar number in the placebo group on the right side. In terms of overall discontinuation, the very, very similar rates of around 12 and 14%, as you can see. Discontinuation due to adverse event, 5.5 versus 5.7%. In terms of the adverse events of interest, in terms of amputation, there was absolutely no difference at all. So there was no concern here about there being amputation in the dapagliflozin group, for example. These were equivalent between the two groups. In terms of DKA, in fact, there were 0 cases of DKA at all in the dapagliflozin group and 0.1% in the placebo group. So extremely few episodes of DKA from the DAPA-CKD study. The fracture rate 4% versus 3.2%, and renal-related adverse events 7.2 versus 8.7%. Hypoglycemic rates extremely low and comparable between the two groups. And in terms of volume depletion, again, pretty much no difference between the two. So this study, in summary, to summarize the safety outcomes, there was really no additional safety concern coming from the DAPA-CKD study. I think this is important because clearly this is an at-risk population. As we all know, patients with CKD are at increased risk generally, including cardiovascular risk, for example, and it's quite pleasing to see that there really doesn't appear to be any additional safety concern from this study, specifically in this at-risk population. So just to summarize the DAPA-CKD then, this is the first dedicated renal outcome trial to assess the efficacy and safety of an SGLT2 inhibitor in patients with CKD with and without type 2 diabetes. In terms of the summary data, 39% relative risk reduction for the primary composite endpoint, 44% for the secondary renal composite endpoint, 29% for the cardiovascular composite of CV death and hospitalization for heart failure, and 31% reduction for all-cause mortality. There were consistent treatment effects in patients with CKD across major subgroups, including with and without type 2 diabetes, and according to baseline EGFR and urinary albumin-to-creatinine ratio. Dapagliflozin was well tolerated and essentially showed no additional safety concerns. DAPA-CKD builds upon the evidence for dapagliflozin in the prevention of hospitalized heart failure and worsening renal disease from the DECLARE study, but also the reduction in the risk of worsening heart failure and CV death in the DAPA-HF study. It's an extremely useful study in addition to our evidence base for this fascinating and emergent treatment class for type 2 diabetes. Personally, I think it's time limited in terms of how we can still talk about this class as being a treatment for type 2 diabetes. I think over time, its indications will become much broader, in my opinion. So in terms of the summary then, putting this in context, this is looking at the three main studies on dapagliflozin, DECLARE, DAPA-HF, and DAPA-CKD. And you can see here on the top line, in terms of the patient groups, remember, DECLARE, about 60% were primary prevention, and 40% had atherosclerotic cardiovascular disease. They had a mean eGFR of 85, so they had normal renal function. In DAPA-HF, remember, this was a group of patients with heart failure with restrictive ejection fraction, with an eGFR greater 30, and the mean eGFR was 66. And DAPA-CKD, remember, renally impaired population, eGFR 25 to 75 with a mean eGFR of 43. Remember, in the case of DAPA-HF and DAPA-CKD, they included both type 2 diabetes and non-diabetic patients. You can see here, shown in purple, the cardiovascular outcome data from each of these studies, and shown in orange, the key renal data outcome for each of these studies. I won't go through these again in detail because I've already covered them in this presentation to date, but suffice it to say that you can see these consistencies between the different studies. If you look, for example, in relation to the renal outcome data, you get consistent effects, and obviously the DAPA-CKD tells us, actually gives us much more useful data because it's specifically powered for a renally impaired population. So let's move on then to the second part of the talk to discuss the credence data, and this is the other major CKD study looking at the in relation to the SGLT2 inhibitor class. As we've heard, the three original CDOTs, DECLARE, CANVAS, EMPA-REG, you can see in the green zone on this chart, in other words, normal renal function, whereas credence very much in the red zone, again, as with DAPA-CKD, looking at patients with chronic kidney disease. As you can see, the mean eGFR of 56 and the median urinary albumin-to-creatinine ratio of 92.7 milligrams per millimole. Here's the study design for the credence study. As you can see, the objective to study the effects of canagliflozin on renal endpoints in adults with type 2 diabetes and chronic kidney disease receiving standard of care, in addition to ACE and ARBs. A key difference between DAPA-CKD and credence is that credence was specifically looking at type 2 diabetes patients. Remember, DAPA-CKD looked at non-diabetic patients as well. In terms of numbers, there are over 4,400 enrolled, as you can see, and similar numbers in each of the groups. Again, it was a one-to-one randomization, a very simple design, looking at canagliflozin 100 milligrams versus placebo. In terms of the inclusion criteria, you can see there adults over 30 years, type 2 diabetes, A1C 6.5 to 12%, eGFR 30 to 90, and a urinary albumin to creatinine ratio of 33.9 to 565.6 milligrams per millimole. They were on stable maximal doses of ACE and ARBs, and there's some various exclusion criteria, as you can see there, which included certain types of chronic kidney disease, dialysis, and renal transplant, for example. The primary endpoint was end-stage kidney disease, doubling of serum creatinine, or renal or CV death. There was also about, I think there were 7 in total secondary endpoints, and you can see, importantly, this included composite MACE outcomes as well, and we'll come on to those later. In terms of the baseline features then of this of the Credence study, you might not be surprised to hear that the vast majority, nearly all of them, were taking ACE or ARBs, 99.9%. About 70% were taking a statin. The mean blood pressure 140/78, and clearly they had blood pressure management as well. The mean A1C 8.3%, a little bit suboptimal, but remember they all had type 2 diabetes, and clearly they all had other diabetic management as well. In terms of the main outcomes from the study, then, students, just remember, anagliflozin or Invokana plus standard of care in terms of the primary renal composite, which was end-stage kidney disease, doubling of serum creatinine, or renal or CV death versus placebo. You can see here the difference favouring canagliflozin, 30% relative risk reduction, which was significant. Okay? In terms of number needed to treat, 22 needed to treat with canagliflozin to prevent 1 event over 2.5 years, as you can see. So in terms of the breaking down these data then, in terms of the composite, you can see the primary composite on the top there, and you can see the various components of that down are on this forest plot. For example, doubling of serum creatinine, end-stage kidney disease, eGFR less than 15, dialysis, renal death, CV death, and so on. Then a couple of other composites there at the bottom, end-stage kidney disease, doubling of serum creatinine, renal death, and then dialysis, kidney transplantation, or renal death. And you can see, it doesn't matter which one you look at, highly consistent between them, okay, all favouring canagliflozin, very similar to the kinds of data that we saw with the DAPA-CKD. In terms of the renal death, you can see there it does in fact cross the midline, but look at how broad that is. I mean, I think that's presumably indicative of the fact that there were very relatively few in terms of numbers, so there was probably a power issue going on there. I'm not sure how much we can place on that based on how broad those kind of 95% confidence intervals are for the renal death, but you can see for all the others, highly consistent effects favouring canagliflozin. In terms of numbers needed to treat, for the primary composite, 22 as we've heard, if you just look at those with an eGFR between 30 and 45, 16, NNT 16 to prevent 1 event over 2.5 years. In anyone's book, that is remarkably good. And you can see the other NNTs there, if you look across the way in terms of the different composites. Hospitalisation for heart failure, 46, for example, and in terms of CV death, non-fatal MI, non-fatal stroke, the NNT was 40. So what about the renal composite across the SGLT2 inhibitor class? Well, when we take a step back and look at the EMPA-REG, Canvas, Declare, Credence at the top there, you can see in terms of patients with atherosclerotic cardiovascular disease, high consistency, all favouring the SGLT2 inhibitor. In patients without atherosclerotic cardiovascular disease, with just multiple risk factors, again, when you look at the Canvas, Declare, and Credence, again, you can see consistency favouring the SGLT2 inhibitor. This is in relation to renal composite outcomes. So huge consistency, regardless of whether or not you have underlying atherosclerotic cardiovascular disease in relation to renal outcomes. When we look at the MACE outcomes, the cardiovascular outcomes, the picture is actually very different. Again, when you look at those with atherosclerotic cardiovascular disease from EMPA-REG, Canvas, Declare, Credence, there's general improvement, general consistency, except that in Declare, this was primarily hospitalisation for heart failure, but you can see there the trend is favouring the SGLT2 inhibitor. When it comes to patients without atherosclerotic cardiovascular disease, just with multiple risk factors, there appears to be very little, if any, effect from the Canvas and Declare study. There was very little, if any, effect from the SGLT2 inhibitor. But when we look at Credence, and this is, I think, a key point from this talk, in patients without atherosclerotic cardiovascular disease, if they had chronic diabetic kidney disease, they still derive benefit from canagliflozin. And I think that's a really important learning point And a take-home message really from this entire talk is that yes, outside of the context of CKD, they haven't got atherosclerotic cardiovascular disease, maybe the effects on cardiovascular outcome aren't as good, but if they have CKD, as at least from the perspective of the credence, there's clearly an effect there. Just to finish off then in the final few minutes, this credence study has led to a change in licensing for canagliflozin, which is really a sea change, really, I think, within the class, because up until this point, we were not able to initiate this class of therapy in patients with an eGFR of less than 60. Whereas now, we can initiate canagliflozin at a dose of 100 milligrams in patients with an eGFR down to 45 without severe albuminuria, defined as a albumin-to-creatinine ratio of 30, and then stop it once the eGFR drops below 30. However, in those patients with severe albuminuria, defined as an albumin-to-creatinine ratio of above 30 milligrams per millimole, 30 is the number, and 30 is on the chart here. Okay, so remember, if you want an aide-memoire, remember, 30 is the cutoff of the ACR, and 30 is the eGFR, what you're allowed to initiate canagliflozin 100 milligrams down to that number. Okay, so in other words, any patient with an eGFR down to 30, if they've got with type 2 diabetes, if they have a severe albuminuria over 30 milligrams per milliliter, you can initiate canagliflozin 100 milligrams, and in fact, you can keep them on it until they go on to dialysis or renal transplantation, okay, which is a massive, really, sea change in how we kind of view and use this class of therapy. Up until this point, the biggest conclusion, really, for using an SGLT2 inhibitor was, in fact, renal dysfunction. And I think another take-home message and another really important point is that the glycemic benefits from this class diminish commensurately with eGFR. In other words, the lower the eGFR, the less the glycemic effect of this class of therapy. But the renal and cardiovascular benefits are maintained regardless of eGFR. So even if you have severe renal impairment, as shown in both DAPA-CKD and credence, you will still get remarkable renal and cardiovascular benefits from this class of therapy. So if you are going to be using this drug with really severe renal impairment, as shown here, for example, clearly you're going to be using it primarily for the renal and cardiovascular benefits, although I should still state that this is still licensed in type 2 diabetes. Okay? The licensing, at least in the UK, does not extend to patients without type 2 diabetes. And in terms of the licensing, obviously glycemic control is still mentioned there, but really in clinical practice, I think that's kind of makes sense and would be the kind of primary rationale, really. So just to summarise then, we've gone through a lot of data here in this 25-minute talk. We've talked about the DAPA-CKD, we've talked about the primary renal composite outcomes from this, we've talked about the credence, we've talked about the differences between the trials. Remember, DAPA-CKD looking at type 2 diabetes and non-diabetic patients, credence specifically in type 2 diabetes, but remarkable similarities between the two classes. And I think we have enough data now to really confirm that this class effect of renal benefits, in addition to the hospitalized heart failure, these remarkably consistent outcomes across the class appear to be class related. I think we obviously are eager to see the equivalent study on empagliflozin, which will obviously add to our evidence base. But I think certainly in terms of the license change for canagliflozin, it's really kind of added really to our clinical armamentarium for managing this really important group of patients with diabetes and CKD. So with that, I'd like to conclude the talk. I'm very happy to take any questions. I'd like to thank the organisers once again for the kind invitation to speak, and thank you all for joining the talk. Thank you.
Tom, thank you for a really clear and succinct summary of all of the evidence in this rapidly moving space. So, time for a couple of quick questions. How long do you think it will take for guidelines on glomerular filtration rate to change with all of this evidence in late nephropathy? That's from Paulo.
Yeah. Well, I mean, it's clearly already changing, isn't it? I mean, the canagliflozin, as I said, I mean, that's really, I think, a sea change. I think it's only a matter of time before, obviously the DAPA-CKD will, similarly be translated into, changes in licensing and guidelines. I mean, I think that's obvious to anyone looking at these data, and one would imagine Similarly with obviously we don't know what the data are going to show with empagliflozin, but assuming it shows similar data, then one would assume the same there. I think as I said earlier, I think the time that we can kind of talk about this class as a diabetes therapy, I think is limited. Okay, I think in my own view, they're kind of almost kind of going into the Premier League, I would say, of therapies in the same class as ACE and ARBs and statins, right? In terms of their effect, they're very much in that ballpark. And some of the evidence that's coming through now is clearly shows that. Okay, and I think over time, clearly, frankly, we'd be doing our patients a disservice if we didn't use them more broadly. And so our renal colleagues and our cardiology colleagues, of course, are very interested in this class, clearly because of the evidence that's coming through, and we all want to do the best for our patients. And I think as diabetologists, we shouldn't be precious about that. We should be actually embrace it and say, well, actually, yeah, that's a great thing, and we're all going to do the same for the best for our patients. Let's make this class as applicable and as beneficial for as many patients as we can. Clearly, that all takes time. I mean, license changing and so on, guidelines changing, as we all know. It happens often at a glacial speed, so we're not expecting this to happen anytime soon, but I think inevitably it will ultimately.
Thank you very much.